A very good evening, everyone. Hello and welcome to this LRR session for INI-CET for your upcoming exams. So, we will be discussing the most important high-yielding topics of pediatrics which are important for your upcoming exams. So, a very good evening to all of you. So, please, can you please confirm if I am audible and if my screen is visible so that we can start? Yes, good evening, Paikia. I can't read your name. Yes. Can someone please give a quick confirmation if my screen is visible and I am audible so that we are good to go? Thanks, Srinidhi. So, we will be starting straight away with the most important topics which you cannot, not afford to miss, right? So, which you must revise before your INI-CET exam, right? And as we've seen in the recent times, there is more and more shift to, analytical kind of questions rather than just rote remembering. So these topics that we'll be discussing will remain important and can be asked in various ways in your upcoming exams, right? And I've included a lot of latest updates and, some controversial areas. So a lot of new things that might be asked for your upcoming exams and remain important. So we are good to go? Yes? Okay. So starting with the first question, so a child presented with decreased pulse in lower limbs, okay. So I want this to be an interactive session. I want all of you to answer, okay, because it is just few more days to go before your exam and you must be really all pumped up now. I'm sure most of you will be able to answer all the questions correctly, right. So a child presented with decreased pulse in lower limbs and delay as compared to pulse felt in upper limb. So whenever you're getting a disparity in the upper limb pulses and the lower limb pulses, what are we going to think of? So, what can be the underlying condition? Yes, I can see Rajesh answering. Absolutely. So, we'll think of coarctation of aorta in this case. Now, what do you mean by coarctation of aorta? So, coarctation of aorta means a narrowing. And where is this narrowing? So, where is this narrowing? So, if you look at the heart, so the right atrium, right ventricle, right? So, you have the right atrium, right ventricle, left atrium, left ventricle. From left ventricle comes the aorta and from right ventricle comes the pulmonary artery or the pulmonary trunk. Now, and there are the branches of arch of aorta which are the, yes, what are the branches of arch of aorta? Brachiocephalic trunk and the left common carotid, left subclavian. Now, there is a narrowing here in this aorta, right? So, there is a narrowing between the arch of aorta and the descending aorta. So, what will happen? The branches of the arch of aorta are getting good blood supply. So, the upper limb, the structures of head and neck, brain, they are getting good blood supply, but the structures of lower limb are getting lesser blood supply. That is why you get a disparity in the pulse, weak pulses. So, whenever you are getting a case scenario where you have weak lower limb pulses, it can be weak femoral pulses, it can be weak dorsalis pedis pulses, popliteal pulses, think of coarctation of aorta. And this narrowing is usually juxtaductal in location, okay. So, the most common location is juxtaductal, that means near, okay. So, near the location of the ductus arteriosus. The clinical features will depend upon the severity of this narrowing. If the narrowing is not very severe, it can just present with some, intermittent claudication of lower limbs. That means pain in the lower limbs on doing physical activity. So, there can be just claudication of lower limbs if it is mild. It can present just with hypertension also. Why hypertension? Because lesser blood is going to, through the branches of descending aorta. So, lesser blood is going to kidneys also, renin-angiotensin system is getting activated. It can present with hypertension alone. So, any child with hypertension, we work up for coarctation of aorta as well, right? And in severe cases, so in severe cases, it is going to present even with heart failure and with absent or feeble lower limb pulses, okay, feeble lower limb pulses. Now, because the branches of the descending aorta are not getting enough blood supply, what will happen? There will be development of collaterals. So, collaterals are going to develop between the branches of arch of aorta and the descending aorta. Because of these collaterals, you will get the clinical manifestations. So, you can get notching of inferior margin of ribs, right? So, we can see in this X-ray. So, this is what you see here. So, you can see these notching of inferior margin of ribs. It is due to the development of collaterals between the anterior intercostal and the posterior intercostal arteries, right? So those collaterals develop, and you can get a murmur also in the around the scapular region on the back because of these collaterals, right? So collaterals develop, and this notching of inferior margin of ribs is usually seen beyond 3 years of age, and it involves 3rd to 9th ribs. And apart from this, you can get a like this 3 sign also, figure of 3 appearance because of the narrowing in the arch of aorta, right? Figure of 3 or E sign can also be there, right? Now what happens, so talking about the other options also. So here the other options are transposition of great arteries, Epstein anomaly, and tetralogy of Fallot, right? So let us talk a little bit about them also, because you can get questions related to them. So transposition of great arteries, what is the basic defect? So normally what happens is, the aorta comes from where? The left ventricle, and the pulmonary artery comes from the right ventricle. Now when it is just opposite of the normal, then it is called transposition of great arteries. So in transposition of great arteries, the basic defect will be from the left ventricle. What will come out? From the left ventricle, instead of aorta, the pulmonary artery will come out, and from the right ventricle, instead of pulmonary artery, the aorta will come out. So this is the basic defect in transposition of great arteries. Now we call it a disease of parallel circulation. Why do we say so? Let us see. So what happens is, why do we call it disease of parallel circulation? Let us see. So there is the right atrium. From that the blood goes to right ventricle. From right ventricle, normally what comes out? Pulmonary artery. But it is TGA, so what will come out? So it is TGA, so aorta will come out from right ventricle, right? So right ventricle, say aorta has come out. Now aorta will supply to all body parts, all organs, and then the venous deoxygenated blood via superior vena cava and inferior vena cava, where do they drain? We know they drain into right atrium. So blood started from right atrium, came back to the right atrium without getting oxygenated in the lungs. What is happening on the left side? Let us see. So blood from left atrium to left ventricle. From left ventricle, normally what comes out? Aorta. But this is TGA. So what will come out? Pulmonary artery. So pulmonary artery blood goes to the lungs, gets oxygenated via pulmonary veins. We know where do the pulmonary veins drain? So pulmonary veins are going to drain into the left atrium. So blood started off from left atrium, came back to the left atrium. The oxygenated blood is circulating without getting distributed to the entire body. So that is why it is called a disease of parallel circulation. 2 parallel circulations are going on. It becomes incompatible with life unless there is communication at any level. So the communication can be in the form of a atrial septal defect or a patent foramen ovale, or it can be in the form of a VSD, or it can be in the form of a PDA, right? Now, if it is TGA with intact ventricular septum, that means no VSD is there, no PDA is there, then the baby might become symptomatic in the first 1 or 2 weeks of life and can present with heart failure. What can you do then? You can do a life-saving procedure which is called balloon atrial septostomy. So it is called Rashkind procedure. So you can do a BAS, that is balloon atrial septostomy or Rashkind procedure. Okay. So you make a big hole. You make a big hole in the atrial septum by this balloon atrial septostomy or Rashkind procedure. So this can be asked in your exam. So Rashkind procedure can be done. And apart from that, what you can do? You can give alprostadil or PGE1 analog to keep the ductus open. So you can give alprostadil or PGE1 analog to keep the ductus open. And the ultimate, curative procedure would be arterial switch operation or Jettine's repair. Arterial switch operation or Jettine's repair. Okay, Jettine's repair. So these are the questions that can be asked, right? And what do you get on an X-ray in TGA? So yes, we all know that we get a egg on side appearance. So you get a egg on side appearance in TGA, right? You can see it looks like an egg. What is the basic defect in Epstein anomaly? So Epstein anomaly was also one of the options. So here what happens is the tricuspid valve is both structurally and functionally abnormal, and it shifts downwards. Okay. So what happens? There is atrialization of the right ventricle. So there is abnormal tricuspid valve both structurally and functionally, and the location is also abnormal. It shifts downward. So there is atrialization of right ventricle. Okay, and all the chambers of heart are hugely enlarged, especially the right atrium. Because all the chambers of heart are hugely enlarged, what will happen? You get a box shaped heart. You can see the cardiac shadow is huge, right? It's the box shaped heart. And on ECG, you can get tall and broad P waves. You can get Himalayan P waves on ECG. P waves looking like Himalaya. So, Himalayan P waves on ECG, right? Right? What do you see here? So, of course, all of us know it. So, this is the boot shaped heart or core and sabot appearance that we get in Tetralogy of Fallot. Along with this, can you appreciate there is pulmonary oligemia? The blood vessels are not very prominent. Now, components of Tetralogy of Fallot remain very important. What are the 4 components? Tetralogy means 4. So, they are a large VSD, pulmonary infundibular stenosis, overriding of aorta and right ventricular hypertrophy. So, you get questions like all of the following are components of TOF except, right? Clinical features. Now, TOF is the most common congenital cyanotic heart disease in children. So, there will be cyanosis, there will be clubbing. Can you appreciate this clubbing? You can get image based questions like this. You can see the clubbing that is there in the, it can be in upper limbs as well as lower limbs. So, cyanosis, clubbing. Because of hypoxia, there is polycythemia and there can be cyanotic spells, right? And because of this polycythemia, there can be complications like, there can be cerebral thrombosis or cerebral abscess. Cerebral thrombosis or cerebral abscess can be there, right? Because of the sluggish blood flow due to polycythemia. Now, pathophysiology and management of cyanotic spells is also very important. Now, in Tetralogy of Fallot, what are the auscultatory findings before coming to the pathophysiology? The auscultatory findings, can someone tell me what happens in Tetralogy of Fallot? Yes. So, auscultation, you get a single second heart sound because P2 is soft and inaudible. And what is the murmur that we get? So, we get ejection systolic murmur in pulmonary area, right? Okay. So, these are the auscultatory findings. Now, more severe the Tetralogy of Fallot, more severe the cyanosis, but lesser is the murmur. Now, what happens in cyanotic spell? So, very, very important, you can get questions related to management of cyanotic spell as well. So, in Tetralogy of Fallot, there is a right to left shunt. And due to any condition, if this right to left shunt further increases, there is a cyanotic spell, or it is also called a TET spell, right? So, right to left shunt further increases. So, further lesser blood goes to the lungs, lesser blood gets oxygenated. So, you have severe hypoxia and the cyanosis deepens. What will happen to the murmur? So, this was asked in the AIIMS exam once. So, what will happen to the murmur in or during cyanotic spell? Yes, can I get the answer? What will happen to the murmur during a cyanotic spell? So, the murmur, remember, will decrease or become absent because we already mentioned more severe the disease, lesser is the murmur. And during cyanotic spell, the severity is increasing. So, the murmur, very good, Anunojoy Kumar. So, yes, Arunojoy, yeah. So, the murmur decreases or becomes absent. And there will be hypercarbia, acidosis, respiratory center in the brain is stimulated, hyperapnea, and it goes on as a vicious cycle. What do you do in the management of cyanotic spell? So, what all can you do? So, you can increase the pressure of the left side by doing systemic vasoconstriction. So, you can use alpha agonists like phenylephrine, beta blockers like propranolol or metoprolol, and in severe cases, you can even use ketamine. Because hypoxia is causing problem, you can give moist oxygen. Hypercarbia, acidosis is causing a problem, so give injection sodium bicarbonate. Respiratory center in the brain is getting stimulated, so you can give morphine to take care of that. And squatting or knee chest position also helps in increasing the systemic vascular resistance. So remember, calcium has no role in the management of Tetralogy of Fallot. So all of the following are used in the management of cyanotic spell except, so answer is usually calcium or isoprenaline. Okay, right. What is Pentalogy of Fallot? Penta we know means 5. So, Pentalogy of Fallot is basically nothing. It is Tetralogy of Fallot, all the 4 components plus atrial septal defect. What is Trilogy of Fallot? So, Trilogy of Fallot is pulmonary stenosis plus atrial septal defect plus right ventricular hypertrophy. So, remember, atrial septal defect is not a component of Tetralogy of Fallot, but it is a component of Pentalogy of Fallot and Trilogy of Fallot. Right? Sorted? So, moving ahead. NADA's minor criteria for congenital heart diseases are. So, before answering this question, let us see the NADA's criteria. We come back to answer this question. So, NADA's criteria basically is used for assessment of presence of congenital heart disease. Assessment of presence of congenital heart disease. It will just tell you whether a congenital heart disease is present or not and nothing more than that. So, you need either one major or two minor criteria to say yes, a congenital heart disease is present. What are the major criteria? So, major criteria include any diastolic murmur, presence of congestive heart failure, cyanosis and systolic murmur greater than equal to grade 3, right. So, NADA's criteria you can remember major learns defense. Yes, a general major in our army learns defense. So, D is for diastolic murmur and F is for failure, right. And cyanosis, you have the C for cyanosis and 3 E's are there. So, systolic murmur greater than equal to grade 3, okay. Now, minor criteria, so remember major learns defense, but minor learns A, B, C, D, E. Yes, a minor means a child, he is going to learn A, B, C, D, E first. So, A is for abnormal, B is for BP, C is for chest x-ray, D is die. Die means two things. What are they? So, one is abnormal second heart sound and systolic murmur grade 2 or less. So, second heart sound and grade 2 or less both have 2 in it and E is for abnormal ECG. So, these are the minor criteria in NADA's criteria. Coming back to our question, so NADA's minor criteria for congenital heart disease are, so is diastolic murmur a major criteria or minor criteria? So, it is a major criteria, not a minor. Low BP or abnormal BP, it is a minor criteria. Systolic murmur less than grade 3 is a minor criteria and abnormal second heart sound is also a minor criteria. So, our best answer will be where there is 2, 3 and 4, that is option B. I can see Ashish has already answered it correctly. Very good Ashish. Okay. Moving ahead, a 13-year-old child is diagnosed with rheumatic fever without carditis or valve damage. What is the duration of secondary prophylaxis required? Is it 5 years, 10 years, 15 years, 20 years? Waiting for your answers. Meanwhile, let us discuss a little bit about rheumatic fever. Okay. So, here there is no carditis and no valve damage. Waiting for your answers. Now, to diagnose rheumatic heart disease or rheumatic fever rather, we have the modified Jones criteria. Now, the latest version had classified all the countries based on whether it is low risk or moderate to high risk. India we know falls in the moderate to high risk category as most of the developing countries. So, why moderate to high risk? So, we are calling it moderate to high risk because the incidence of acute rheumatic fever is more than 2 per 1 lakh school age children, or the prevalence of RHD is more than 1 per 1000 population per year cumulative. So, India falls in the moderate to high risk. So, because India is in moderate to high risk group, the modified Jones criteria, major criteria would become, so carditis. Carditis is one of the criteria. Now, carditis can be either clinical or subclinical, okay, clinical or even subclinical. You are not getting any murmur, no clinical feature, but echocardiographic evidence, echocardiogram evidence will also count. Arthritis. Now, this arthritis in this high risk population, we have it includes polyarthritis. So, classically migratory polyarthritis is what was taught to us in rheumatic fever, but even monoarthritis, okay, and even polyarthralgia, that means joint swelling is not there, only pain is there in multiple joints, polyarthralgia, all these count as arthritis. Chorea, erythema marginatum and subcutaneous nodules. Of these, the most common manifestation of course is arthritis. So, these are the major criteria. What about the minor criteria? So, minor criteria would be monoarthralgia, fever, these two are clinical and these two are lab. Elevated ESR or CRP, that means evidence of inflammation, and ECG changes in the form of prolonged PR interval. And there is an essential criteria, there should be evidence of antecedent streptococcal infection. That can be in the form of throat swab culture or rapid antigen detection test or elevated ASO titers. Now, to diagnose rheumatic fever, initial episode we need either 2 major or 1 major plus 2 minor criteria, and plus of course essential criteria is required in all cases. To diagnose a recurrence, you can either take 2 major or 1 major plus 2 minor, or even 3 minor criteria alone are sufficient to diagnose recurrence, especially in high risk areas like India. Okay. Now, how do you prevent rheumatic fever? So, primary prophylaxis is any streptococcal infection should be treated as soon as possible to prevent an attack of rheumatic fever. So, any streptococcal infection like sore throat should be treated with appropriate antibiotics within 9 days of onset. This was asked once, okay, within how many days of onset? Now, secondary prophylaxis, usually the drug used is injection benzathine penicillin. It is to be given intramuscularly every 3 to 4 weeks. Now, why is this given? Because once acute rheumatic fever happens, every time the child or individual is going to have a streptococcal infection, again a recurrent attack of rheumatic fever can come. So, to prevent that recurrent attack, we are giving this prophylaxis to prevent streptococcal infection. Okay. So, less than equal to 27 kgs, the dose will be 6 lakh international units, more than 27 kgs, 1.2 million units. Now, the question is that for how long do you give this prophylaxis? Now, if there has been no carditis, we can safely give it for next 5 years or till 18 years of age. If with carditis but without residual heart disease, for next 10 years or till 21 years of age. And if residual heart disease is present, you need to give it for at least 10 years and till 40 years of lifelong. Okay, right? So, coming back to our question, so because there is no carditis, no valve damage, so we would like to give it for at least 5 years. Okay. Moving ahead to the next question. An otherwise well child. So, an otherwise well child, okay, an otherwise well child presents with petechiae, purpura. So, otherwise well child. So, well child is very important fact here. Well child, okay, not a sick looking child. Presents with petechiae, purpura and a platelet count of 10,000. So, there is severe thrombocytopenia. Okay, there is thrombocytopenia. Bone marrow examination reveals increased megakaryocytes. Which of the following is the drug of choice? Now, here, what is your diagnosis first? So, our diagnosis here is acute ITP. So, in a well child, if there is thrombocytopenia and the bone marrow examination is normal, other cell lines are normal, our diagnosis is acute immune thrombocytopenic purpura. Now, bone marrow transplant usually not required for acute ITP because it can be a self-limiting illness, otherwise it responds very well to treatment. Methotrexate again is not indicated. I can see most of you answering correctly. So, Shalu, Tawfiq, Ashutosh, Mantasha, Himanshi, Sushant, very good. So, IVIG is the drug of choice. Alternatively, corticosteroids, a short course can also be used. Okay. Aspirin, we will not, prefer because aspirin as it is what it causes. So, it causes platelet dysfunction and it can cause even, bleeding. So, in a child already having thrombocytopenia, we are not going to use aspirin. So, our best answer is IVIG. Okay. Now, what are the treatment options for acute ITP? Let us discuss a little bit. The latest recommendations say that if there is no bleeding or only mild bleeding, then observation alone is the first line of treatment. You need not give any treatment. So, if there is no bleeding or mild bleeding means only petechiae or bruises are there, no active bleeding. Observation alone is sufficient. But if there is mucocutaneous bleeding, you can use either intravenous immunoglobulin or a short course of oral corticosteroids. But if there is life-threatening hemorrhage, then splenectomy is used. And platelet transfusions are also avoided unless there is life-threatening hemorrhage like a intracranial bleed. Okay, only then you would give a platelet transfusion. Okay, or splenectomy. Otherwise, not. Okay. Now, for chronic ITP, splenectomy can be done. Splenectomy can be done for children with severe ITP with symptoms lasting for more than 1 year and the symptoms are not getting easily controlled by therapy. Alternative to splenectomy, we can also use rituximab, okay, anti-CD20. And TPO receptors agonists like L-trombopag and romiplostim can be used, but they are useful only in chronic ITP, not in acute cases. Right? So, moving ahead, a 2-year-old child. So, there is this 2-year-old child who presents with pallor, hemolytic facies and splenomegaly. So, if you are getting pallor, hemolytic facies and splenomegaly, what do you think of? First tell me, what do you think of? So, we will think of, yes, waiting for your replies, I am not answering right now. What investigations we will do? So, of course, here we are suspecting, yes, chronic hemolytic anemias. Can you give me some example of chronic hemolytic anemias? Yes. Waiting for your reply. So, chronic hemolytic anemias can be like thalassemia, sickle cell disease, any other hemoglobinopathy, right? What are the investigations you will do for workup? So, will you do a peripheral smear? Yes, peripheral smear will give us evidence of hemolysis. It will show us abnormal cells like sickle cells if present. Hemoglobin HPLC will be very useful in diagnosing thalassemia, sickle cell anemia, any other hemoglobinopathy. Yes. Bone marrow aspiration is usually not required if there is only pallor and you are getting evidence of hemolysis. We are not suspecting pancytopenia. Usually we will not resort to bone marrow aspiration as the first line. PT-APTT is also usually not required as we are not suspecting a coagulation disorder here, right? So our correct answer would be where option 1 and 2 is there, that is A. So I can see Himanshi has answered correctly. Good Himanshi, and Ashish as well. Ashish Saini. Great. Proud of you. So this is what a hemolytic facies looks like. Okay. So you can get image based question also. You can see there is a frontal prominence, frontal bossing is there. There is depressed bridge of nose. There is malar prominence, and you can also get maloccluded teeth or prominent teeth can be there. Okay. Now, this is what a hemoglobin HPLC or electrophoresis report looks like. So, you can get standalone questions with these images accompanying. That's why I gave an image also here, so that you know if you have these image based questions, you don't get boggled. What do you see here? So, what you can see is there is a HbF peak. You can see there is hardly any HbA. We cannot see HbA. You get a big HbS peak here. So, big HbS peak here with hardly any HbA. So, this points to a diagnosis of sickle cell disease, right? So, this is what a hemoglobin HPLC or electrophoresis report would look like, okay? So, moving ahead, and you know, of course, the confirmatory diagnosis would be genetic. So, confirmatory diagnosis, if someone asks you, you have to do the globin gene mutation, okay? Right. So, this was also asked once, what would be the confirmatory diagnosis, okay. Now, a 4-year-old boy, presents with recurrent episodes of swelling of right knee following trauma. So, you can see recurrent episodes of right knee swelling following trauma. So, there could be trauma could cause some bleeding leading to joint swelling again and again. There is a history of similar illness in his maternal uncle. So, what is the disease that we are thinking of? Yes. And the question says all of the following are true regarding this illness except. So, the first step here is to diagnose this condition. Next step is you have to answer the questions related to it. Okay. Yes. So, we are thinking of very good black pearl. So, we are thinking of hemophilia here, of course. So, the classical hemophilia or hemophilia A we know is factor VIII deficiency. The question is asking all of the following are true regarding this illness except. So, factor VIII deficiency is true. X-linked recessive inheritance, yes, it has X-linked recessive inheritance, and that is the reason that it is seen in the boy, and there is a history of maternal uncle being affected. So, that is what typically happens in a disease with X-linked recessive inheritance. Males are more commonly affected, more common in males. Mucosal bleeding is seen commonly is unfortunately not correct. So, in hemophilia or coagulation disorders, deep bleeding like joint bleeding, intracranial bleed. So, deep bleeding is more common, muscle hematomas. Mucosal bleeding or superficial bleedings are not very commonly seen. Okay, superficial or mucosal bleedings are more seen in platelet disorders of platelet, right? Okay, so the best answer is D. I can see most of you have answered it correctly. Okay, so yes, hemarthrosis is what is happening here. It is common in them. Now, what happens in hemophilia A? So, we said hemophilia A, there is deficiency of this factor VIII, and factor VIII is a part of the intrinsic pathway. So, what is going to be prolonged? The APTT is going to be prolonged, but the PT which comes from the extrinsic pathway would remain normal. Similarly, in hemophilia B, again hemophilia B factor IX deficiency, the same thing is going to happen. It also has X-linked recessive inheritance, and APTT will get prolonged. Okay. Now, hemophilia C factor XI deficiency also APTT is prolonged, but it has autosomal recessive inheritance, not the X-linked one. But classically by hemophilia, if nothing else is mentioned, we will take it as hemophilia A, that is factor VIII deficiency. Okay. Now, in factor VIII deficiency, what all you can use in treatment in hemophilia? So, in hemophilia for the treatment, we can give FFP. We are talking of course about hemophilia A. Okay, hemophilia A, what all you can use as treatment? You can use FFP, you can use factor VIII concentrates. Okay, you can even use cryoprecipitate. But we cannot use cryoprecipitate in hemophilia B. Hemophilia B, we cannot use it. Okay, remember. And there is a newer drug also that has come up for hemophilia. So that can be asked. So a new drug for hemophilia A in children is now available, which is emicizumab. Emicizumab, okay. So it mimics the function, okay. It mimics the function of clotting factor 8. It is a monoclonal antibody that mimics the function of factor 8 and replaces the function of the missing factor 8, right. So you can use this emicizumab, which can be asked for you. Okay. Moving ahead to the next question. What we have here is a male infant who presents with eczema, recurrent otitis media, pneumonia, easy bruising. So what are the noteworthy points here? Eczema or skin involvement is there. Recurrent otitis media and pneumonia means recurrent infections are there. Easy bruising means some bleeding manifestations are there. On examination, there is also petechiae. And lab findings reveal a platelet count of 25,000, that is thrombocytopenia. Platelets are small in size, so microthrombocytopenia. And serum IgM is low, IgG is normal, IgA and IgE are elevated. Which of the following statements regarding this condition are true? So first, who will tell me what is the condition that we are dealing with? Yes, waiting for your replies. What is the condition? So this is a typical favorite of the INI-CET exam, right? Many times repeated. So very good. So I can see Ajju and Sushant and Jayasai Ramvat, Shivgere, Mantasha, yes. So we are of course dealing with Wiskott-Aldrich syndrome here. Okay, so Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, we know what is the, the gene involved. So it is the WAS, Wiskott-Aldrich syndrome gene, and the protein is the WASP protein. Right, and it is on the X chromosome. This gene is on the X chromosome. Because this gene is on the X chromosome, the mode of inheritance would be X-linked recessive, X-linked recessive inheritance. So it is more common in males, right? And there is this typical triad of recurrent infections, eczema and thrombocytopenia. RET, you can remember, recurrent infections, eczema, thrombocytopenia. So let us see which of the following statements are true about this. The condition shows autosomal recessive inheritance due to ADA mutation. Is it true? No. We already mentioned it has X-linked recessive inheritance, and ADA mutation is seen in SCID, severe combined immunodeficiency, not in Wiskott-Aldrich. Here the VAS gene is involved. Characterized by atopic dermatitis and thrombocytopenic purpura is correct. Hematopoietic stem cell transplant is the treatment of choice. Yes, it is also correct. And it is seen more commonly in males. Of course, it has got X-linked recessive inheritance, so more common in males. Okay. So statements 2, 3 and 4 are correct. So easy peasy. Option D is our best answer. So I can see Sushant Rawat, Doc Vishnu, Ashish, Ajju, they've answered option D. Good job. Moving ahead, an infant of 2 months age. An infant of 2 months age was brought with multiple episodes of watery diarrhea and altered sensorium. Which of the following are possible based on the above findings? Now, whenever a child with diarrhea has altered sensorium, what could be the possibilities? Can it be severe dehydration? Yes, we know in severe dehydration the child would be lethargic, can even be comatose. Okay. Can it be hemolytic uremic syndrome? So, hemolytic uremic syndrome usually does not cause altered sensorium. Okay, usually it will not, but if there is severe uremia, it may sometimes cause. What is hemolytic uremic syndrome, by the way? So, HUS or hemolytic uremic syndrome again is a triad. Okay, so it is a triad of microangiopathic hemolytic anemia, thrombocytopenia and acute kidney injury. Now, it can be either D plus HUS, which follows diarrhea, or classical HUS. It can be D minus HUS, which is due to problems in the alternate complement pathway. Okay, alternate complement pathway. So, D minus HUS, especially for the treatment, we use plasmapheresis or plasma exchanges. Okay, you can use immunosuppressive agents, immunomodulators, immunosuppressive agents can be used. And a new drug which can be used is eculizumab, the terminal complement complex forming inhibitor. So, eculizumab can also be used, right? And of course, in HUS and peripheral smear, you get schistocytes or broken RBCs. So, HUS usually typically will not present, with watery diarrhea and altered sensorium. Hypo or hypernatremia can very well cause altered sensorium. And what about cerebral venous thrombosis? Yes, dehydration. Severe dehydration is one of the very important predisposing factors for cerebral venous thrombosis in children, which can present with altered sensorium, seizures, etc. So, the possibilities, the best possibilities are options 1, 3 and 4, which is there in option C. So, I can see Himanshi, Shreyash, Ashish, Mantasha, Doc Vishnu, no, but Ashutosh Jha, and then he modified yes. So, you can see, so many of you are answering it correctly, right? So, we have to, sort of correlate many things together and integrate them to answer the question, right? A little bit more detail about diarrhea is required because questions related to diarrhea come in various forms. So, assessment of dehydration in a child with diarrhea is very, very important for every exam. So, so we have no dehydration, some dehydration, severe dehydration. In no dehydration, what happens? In no dehydration, the child is well alert. Sensorium is normal. In some dehydration, restless, irritable. In severe dehydration, the child is lethargic and may even be comatose, as we saw. Right? What about thirst? The child drinks normally, not thirsty in no dehydration. Thirsty, drinks eagerly in some dehydration, and the child is not able to drink or feed in severe dehydration, not able to drink, so sick. Skin pinch goes back quickly, no dehydration, goes back slowly, some dehydration, but in less than 2 seconds. But if goes back very slowly, taking more than 2 seconds, then it is severe dehydration. Mucosa is moist in no dehydration but dry or very dry and severe. Eyes are sunken and tears are absent. So, the most important things are sensorium, thirst and skin pinch. Again, which of these can you tell me is most important method of assessing dehydration in a child with severe acute malnutrition? Yes, this has been asked previously. In a child with severe acute malnutrition, which is the best way? So, Vishnu is asking why cerebral vein thrombosis is correct, because Vishnu, cerebral venous thrombosis in children, the most common cause is severe dehydration due to diarrhea. What happens is in diarrhea, if there is severe dehydration, the blood will become what? Very thick, right? Severe dehydration, the blood becomes thick. And what happens? There is sluggish blood flow. So, hematocrit increases, sluggish blood flow, so it predisposes through thrombosis. So, cerebral venous thrombosis can happen. Not very uncommon, okay. So, so very good, I can see Vishnu answering. So, Sam, in a child with severe acute malnutrition, the best method to assess dehydration is thirst, right? Because sensorium you cannot rely upon, because in a child with kwashiorkor, anyways the child will be dull and apathetic. Skin pinch you cannot rely upon because subcutaneous fat is not there, skin pinch will go slowly even if there is no dehydration. So, thirst would be the most important one to diagnose the degree of dehydration in a child with severe acute malnutrition, okay. Moving ahead, the treatment of dehydration in a child with diarrhea. Now, in a child with diarrhea, if there is no dehydration, do we need to give extra fluids? Yes, no? Of course, yes. Why? To replace the ongoing losses. If you do not replace it, the child will land up in dehydration. How much fluid do you give? So, in no dehydration, we are going to give 5 to 10 ml per kg per loose stool. And we give it in the form of WHO ORS, right? What about some dehydration? So, some dehydration we usually give around 75 ml per kg fluid over 4 hours, plus of course ongoing replacement of ongoing losses also, okay. So, what you do in no dehydration is also called plan A, okay. In some dehydration what you do is called plan B, okay. And this usually we do it as WHO ORS unless the child has severe vomiting, then we may resort to IV, okay, if the child has severe vomiting then. Now, severe dehydration, what will you do? Severe dehydration, that is called plan C, and we have to give 100 ml per kg fluid, and this has to be IV. What is the fluid of choice? The fluid of choice is, so all these are individual questions in themselves. Fluid of choice is ringolactate in 5% dextrose. Why ringolactate? Because it has potassium as well, and in stool lot of potassium is lost. If this is not there in your options, ringolactate alone is the best answer. If that is also not there in the options, only then you select normal saline, okay. Now, in severe dehydration, we said 100 ml per kg. How fast do we give it? So, we divide it into first 30 ml per kg and the next 70 ml per kg. 30 plus 70 is 100, right? So, in a child less than 1 year age, we give it slowly. So, first 30 ml per kg over 1 hour, next 70 ml per kg over 5 hours, so total over 6 hours. But in a child more than 1 year of age, the first 30 ml per kg we give it over half an hour, next 70 ml per kg over 2.5 hours, and total time taken is 3 hours only. Okay, right? Now, composition of the new WHO ORS, or it is also called reduced osmolarity ORS, is important. We have a sodium of 75 and glucose of 75, potassium 20, chloride 65, citrate 10, making a total osmolarity is asked sometimes, so that is 245. Okay, in the current WHO ORS, 245 milliosmoles per liter. Okay, right? Now, it is different from Resomal. Okay, Resomal is what? Resomal is rehydration solution for malnourished child. Resomal is rehydration solution for malnourished child. Resomal has lesser sodium because malnourished children may have edema. We do not want to give more sodium to them, and it has more potassium because malnourished children have severe hypokalemia. And it also has got micronutrients. Okay, right? Moving ahead, an 8-week-old infant. So, an 8-week-old infant presents with a history of non-bilious, non-projectile vomiting starting at 6 weeks of age. 8-week-old, non-bilious, non-projectile vomiting starting at 6 weeks age, and the infant's abdominal examination reveals visible peristalsis and a small lump palpable occasionally. Which of the following is the most likely diagnosis? So, all of us know this is a typical case scenario of congenital hypertrophic pyloric stenosis. Yes, I can see Shiv Gajera and Shreyash and Mantasha, Black Pearl, not Black Pearl, and Aju. It's okay. So, you may get some questions wrong here. So, no, don't hesitate even if you are getting your questions wrong here. The important thing is you learn it from here and don't make it wrong in your actual exam which is coming up. So, you need not erase your answer if that is wrong. It is absolutely acceptable. What is important is please learn from it and do not repeat that mistake. Okay, no problem, right? Okay. So, congenital hypertrophic pyloric stenosis, this is the typical presentation, non-bilious, and it can be actually projectile vomiting. Here it is non-projectile mentioned, usually it is projectile vomiting. But the other things like non-bilious vomiting, visible peristalsis, lump palpable occasionally, all these favor, and the age group, all these favor a diagnosis of congenital hypertrophic pyloric stenosis. Okay, everything might not fit in the case scenario, but if 4 out of 5 things are fitting in a particular condition, we go with that. Okay, because in medicine it's not always true that everything will happen in a textbook like picture, right? But most of the things are favoring what? You have to see that. Now, GERD or gastroesophageal reflux disease, it is not so because you do not get visible peristalsis, you do not get a lump palpable in GERD, but of course you can get this non-bilious, non-projectile vomiting can be there, right? Cow milk protein allergy also will not present like this. It will present with GI abnormalities. They can be, they can be diarrhea, they can be vomiting, they can be upper GI bleeds and so on. Intestinal obstruction will typically present with abdominal distension, constipation, usually bilious vomiting, and on an X-ray erect posture abdomen, you will see multiple air fluid levels. Okay. So, congenital hypertrophic pyloric stenosis, usual age of presentation is this only around, between 3 to 12 weeks. So, typically around 6 to 8 weeks is the usual age of presentation. Maternal intake of erythromycin, macrolides like erythromycin during pregnancy, of course, or azithromycin during pregnancy in antenatal period is a risk factor. The typical electrolyte abnormalities are sometimes asked. So, you get what? You get hypokalemic, hypochloremic, metabolic alkalosis. Okay. So, that is a typical electrolyte abnormality, and normal saline is usually the fluid of choice for initial resuscitation, and you have to do a pylorotomy. So, ultimately surgical correction will be required. And you have a lot of radiological signs here also, donut sign and target sign, a lot of radiological signs that can come related to this, and antral nipple sign for congenital hypertrophic pyloric stenosis, okay, with paradoxical aciduria, of course. Vishnu, you're right, okay. So, a 2-year-old boy is brought to the clinic for evaluation of chronic cough, recurrent respiratory infections and poor growth. So, chronic cough, recurrent infections, poor growth, what are the bells that ring in your mind? What is the diagnosis? Diagnosis can be made if you read till here only, but of course, we have to read the full question before answering. His parents report that he sweats excessively, has a salty taste on his skin. His older sibling has a similar history, so family history of similar recurrent lung infections and digestive problems. A sweat chloride test was performed which shows equivocal results 65 milliequivalents per liter. Which of the following best describes the inheritance pattern and the gene involved? So, what is the diagnosis first? So, we all know the diagnosis is cystic fibrosis, and I can see most of you, almost all of you have answered this question correctly. So, cystic fibrosis, of course, the gene involved is CFTR gene. It has got autosomal recessive inheritance, chromosome 7. Long arm is the position for this gene. CFTR is a huge gene and more than 1000 mutations are known in this gene. But one of the common mutations has been asked previously in the questions. One of the common mutations is delta F508. What does this delta F508 means? Delta means deletion, F means phenylalanine, 508 is the position from where it is deleted because of the mutation. This is one of the commonest mutations seen in the Indian population, but there are thousands of mutations, as I said. Now, what is the diagnostic criteria for cystic fibrosis? So, there are some clinical criteria, some lab criteria. You need 1 out of clinical criteria and 1 out of lab criteria to diagnose it. Clinical criteria includes clinical features compatible with a diagnosis of CF. Clinical features history of CF. What are the clinical features? So, they are recurrent pneumonia, recurrent diarrhea, and there is steatorrhea or fat in stool, because what is happening, the pancreatic exocrine function, pancreatic enzymes are not releasing properly. Okay, so there is malabsorption of fat, so there is fat in stool, steatorrhea. There can even be oil in stool, visible oil can be there in stool, and there's failure to thrive. Okay, there can be jaundice in the newborn period, there can be meconium ileus, meconium peritonitis, and so on. Family history of first degree relative affected. So, you can get a family history of siblings affected, okay, because it has autosomal recessive inheritance. Newborn screening for CF can be positive. What is the newborn screening test used for cystic fibrosis? Yes, so it is IRT. IRT is immunoreactive trypsinogen. Immunoreactive trypsinogen, okay. So, any of these you need. And the lab criteria, sweat chloride more than 60 milliequivalents per liter on 2 separate occasions, okay, on 2 separate occasions. Apart from that, CFTR, so 2 or more pathogenic mutations in the CFTR gene is required, and abnormal nasal membrane potential transepithelial potential difference, okay. So, any of these. So, you need 1 out of the 3 clinical and 1 out of the 3 lab criteria to diagnose cystic fibrosis, okay. And enzyme replacement therapy is available. Nowadays, newer drugs are available like ivacaftor, lumicaftor and all that, right. Moving ahead. A 4-year-old boy. So, there's a 4-year-old boy who presents with a barking cough, inspiratory stridor. So, cough with stridor and fever for 1 day. On examination, he has mild respiratory distress but maintains oxygen saturation. A neck x-ray shown below. So, it is a very cliche kind of a question. So, many times, in various forms it has come in these exams. So, what you can see in this x-ray? So, you can see what is this? So, this is the steeple sign. You can see the airway looks like the steeple of a church. So, there is this narrowing in the airway. It looks like the steeple of the church. So, it is the steeple sign. And where do you get steeple sign? So, steeple sign is seen in what is the diagnosis? So, our diagnosis here is croup or acute laryngotracheobronchitis. So, our diagnosis is croup or acute laryngotracheobronchitis. And it is a case of mild croup. Why mild we are saying? Because the child is maintaining oxygen saturation, has only mild respiratory distress. The child is not very sick looking, okay. Now, what is the most appropriate initial treatment? Before answering this, let us discuss a little bit about croup and acute epiglottitis, then we come back to answer this question, okay. Now, croup. So, croup is a viral illness. We all know croup is viral illness. The most common cause is parainfluenza virus, but other viruses can also cause it. So, parainfluenza virus. What about acute epiglottitis? It is a bacterial illness. Acute epiglottitis is a bacterial illness, okay. And the most common, so this is a controversial question, but the most common cause in the immunized population now is believed to be streptococcus. Previously, the most common cause was H. influenzae. But now what is happening? We are giving the pentavalent vaccine to everyone. So H influenza vaccination we are already doing. So most common cause now in the vaccinated population is believed to be streptococcus. Okay. Now clinical presentation. Croup, what will happen? Croup is a typical viral illness. So the child will have low grade fever and viral prodromal features like malaise and all that. And there will be stridor, of course, will be there in both croup and acute epiglottitis. And the child can have mild respiratory distress, okay, and so on. So it is a milder kind of illness. And the X-ray, of course, shows the steeple sign as we saw. What about acute epiglottitis? So acute epiglottitis, and yes, barking of course will be there as was there in the case scenario. In both of these it will be there. In acute epiglottitis, there is high grade fever. Sick looking or toxic child, okay, sick looking or toxic child. So from the case scenario, you can get these clues. And the child has so severe respiratory distress, the child is not able to swallow his or her own saliva. So there is drooling of saliva. Okay, drooling of saliva, and you get a thumb sign on X-ray, and you get cherry red epiglottis on laryngoscopy. So this is what the thumb sign looks like. You can see it is like a thumb on the lateral X-ray of neck, and you can see this cherry red or congested epiglottis. So this is what is normal, and this is what is cherry red epiglottis in acute epiglottitis. It is a more severe illness. Okay, so these can come as image based questions. Yes. And treatment. Now because croup is a viral illness, no role of antibiotics in croup. So supportive care is important in both. What do you mean by supportive care? So you start IV fluids, give oxygen if required. So supportive care both acute epiglottitis and croup. Now in croup, in mild cases, the treatment of choice is single dose dexamethasone. You can give it orally, you can give it IM, you can even give it IV. So single dose dexamethasone is the treatment of choice. Okay, while in moderate to severe cases, it is nebulized epinephrine is added. So nebulized epinephrine is added to it. And yes, the child can sit in tripod position to splint his or her own airway to make the breathing more comfortable. Yes, that can be there. Acute epiglottitis, what is happening? It is a bacterial illness. So apart from the supportive care, of course, which is there, apart from the supportive care, the IV antibiotics are the treatment of choice. So IV third generation cephalosporins like ceftriaxone is the treatment of choice. Okay. Now previously racemic epinephrine was told, but nowadays it has been seen that any kind of epinephrine you give, it has the same efficacy. It's not like racemic epinephrine is better. Okay. So which is the most appropriate initial therapy? Now because it is a case of mild croup, we would like to give single dose dexamethasone. So nebulized racemic epinephrine not required, dexamethasone 0.6 mg per kg oral or IV or IM single dose is a treatment of choice. Amoxicillin not required, it is not a bacterial illness. Humidified oxygen with supportive care only will not suffice. Of course humidified oxygen is required, supportive care is required, but that only might not suffice. Okay. So our best answer is option B. You have to read the wordings of all the questions carefully. So Vishnu is asking differentiate between laryngomalacia and acute epiglottitis on laryngoscopy. So laryngomalacia, what will happen? So in laryngomalacia, the epiglottis will look lax like this. A omega sign is there, and the epiglottis will not look so red and congested. Like you can see in acute epiglottitis, it is red, congested, swollen. In laryngomalacia, the epiglottis will not be congested or swollen. It will just be lax and curled over itself, looking like omega. Okay. And it is a self-limiting illness, laryngomalacia. Now moving ahead, a 7-year-old boy. So we have a 7-year-old boy with a history of moderate persistent asthma who presents to the emergency department with severe shortness of breath, audible wheeze, speaking only in short phrases. So we are dealing with, what is my diagnosis here? So I am waiting for your answers before I tell you. Okay, Vishnu, my pleasure. So on examination, his SpO2 is 88% on room air. So there is hypoxia also starting. Accessory muscle use is there. He has already received 3 doses of nebulized albuterol, means salbutamol, and oral corticosteroids also. Despite this, there is minimal improvement. Which of the following is the most appropriate next step? So we are dealing with, yes, Vishnu, it is an acute asthma attack. We call it status asthmaticus, like status epilepticus, status asthmaticus, or we can call it acute severe asthma. Acute severe or severe acute asthma. Okay. Now, what is the management? So coming back to the next step in management, so let us first discuss a little bit about the management of acute severe asthma, then we come back to answer this question, okay? So if there is severe respiratory distress, poor response to the initial salbutamol nebulization and concern for potential respiratory failure and arrest, then of course we will admit the child to PICU like in this case. Supplemental oxygen is required because most of the cases are accompanied by hypoxia, like here also you can see 88%. Frequent or continuous administration of inhaled bronchodilator. So salbutamol continuous nebulization is what we usually do, or back-to-back nebulization. And systemic corticosteroid therapy. So it has been seen that oral is equally efficacious as IV. So if the child is not very sick, able to take orally, you give it as oral. If the child is very sick, not able to take orally, then you give it as IV. Okay, corticosteroids. Now, if there is no response, not much response to this, you add on inhaled ipratropium, which is an anticholinergic. Apart from that, the next line would be IV magnesium sulfate. Magnesium sulfate has been shown to help in severe cases which are not responding to, back-to-back or continuous nebulization as well as steroids, okay. You can also use inhaled heliox, which is a mixture of helium and oxygen. How does it help? Now, helium we know has a very low density, okay. So, atomic weight is only 2, hydrogen, helium, periodic table, remember. So, heliox has got a very low density, so it can easily go through the narrow airways. It can go more easily than air, and it creates less turbulence. So, even the narrow airways, through the narrow airways, it can go easily in a laminar flow and can, make oxygen reach the alveoli. So, heliox mixture can also be used if available. Non-invasive positive pressure ventilation techniques like continuous positive airway pressure or BiPAP can be of use. And if the child is not improving with all these, you can use parenteral beta agonists like epinephrine or terbutaline. Now, why injectable? So, because what happens if the narrowing of the distal airways is very constricted, the inhaled salbutamol or nebulized or MDI that you are giving may not reach the narrow distal airways. So, for that you may need to give it systemically through IV or IM or subcutaneous route. So, IV or subcutaneous route. So, now what is happening, the child is having, you can see there is shortness of breath and severe shortness of breath, audible wheeze, speaking only in short phrases, hypoxia is developing, accessory use. Already we have given nebulized salbutamol and oral steroids. Now, what is the next step? Endotracheal intubation we will not do straight away, we will try other things first, like we will try magnesium sulfate, we will try ipratropium, we can try non-invasive ventilation, we can try injectable beta agonists, right? Administer intravenous magnesium sulfate, yes, that appears to be a good option. Shreya, Shova, Shivani, Aju have answered it correctly already, very good. Begin leukotriene receptor antagonist therapy. So, leukotriene antagonist therapy like montelukast are not very helpful in the immediate period. They are more useful as prophylaxis or long-term management, okay. So, not very effective in acute severe asthma. Start oral antibiotics usually not required if you are not suspecting a superadded or accompanying bacterial infection or pneumonia. So, our best answer is administer IV magnesium sulfate, okay. So, we are good to go, right. So, a 3-year-old child has accidentally aspirated a peanut and suddenly starts coughing. He is brought to the pediatric emergency in an unconscious state. What is the appropriate immediate management? So, don't jump and answer it as abdominal thrust or Heimlich maneuver, which is what we usually do in children with foreign body. Let us discuss the management and come back to this question, okay. So, now management of foreign body aspiration is different in an infant and in a child. So, in an infant, if it is a responsive infant, we will use 5 back slaps like this, followed by 5 chest thrusts. So, 5 back slaps and 5 chest thrusts with the head in the lower position as compared to the rest of the body, so that the foreign body gets expelled, okay. So, you can see 5 back slaps followed by 5 chest thrusts with the head in the lower down position, till the object is removed or infant becomes asymptomatic, unresponsive, till the infant becomes unresponsive. Do not use abdominal thrusts. But if the victim becomes unresponsive, you have to start CPR starting with chest compressions. Unresponsive patient, start CPR or chest compressions. Now, what about older children? Again, if it is this holding the neck like this is called the universal choking sign. Sometimes the child is not able to speak at all. Universal choking sign makes you suspect a foreign body. If the child is conscious, use Heimlich's maneuver or abdominal thrusts in a responsive child. But again, if the child is unresponsive, what will you do? You have to begin CPR starting with chest compressions, right? Coming back to our question. So here the child has been brought in an unconscious state. So unconscious state is the catch here. So what will you do? We will not do abdominal thrust, we will not do back slaps. This is a 3-year child anyways. We will start chest compressions. Okay, endotracheal intubation comes later. Only if the child continues to be unresponsive, then. So chest compressions is the management of choice out of the given options, best answer. Okay. Moving ahead, a 9-month-old child presents with fever and cough. The baby is otherwise active, playful and feeding well on breast. Okay. And there are no chest retractions, respiratory rate is 46 breaths per minute. What is the management? So here the question of course is on the IMNCI, right? So IMNCI is the integrated management of neonatal and childhood illness. Algorithms are there for fever and difficulty, cough and difficulty in breathing. We'll be coming to the answer. Meanwhile, let us discuss IMNCI guidelines of a child with cough or difficulty in breathing. First thing you see is whether fast breathing is there or not. What's the cutoff for fast breathing? Less than 2 months age. We call it fast breathing if the respiratory rate is more than 60 per minute. 2 to 12 months if it is more than 50 per minute, and 1 to 5 years if it is more than 40 per minute. So in this case our child is 9-month-old. So cutoff for fast breathing would be 50. So respiratory rate is 46. That means no fast breathing is there. Fast breathing is not there. Right? What about the general danger signs? General danger signs include what all? So general danger signs include if the child is having convulsions or seizures, the child is having lethargy, inability to feed, persistent vomiting, okay, or if there is stridor in a calm child, then also we consider it as a severe illness. Okay. So now how do you classify? So if the child has got any general danger sign or stridor in a calm child, irrespective of whether fast breathing or chest indrawing is there or not, we classify it as severe pneumonia or very severe disease. So you give first dose antibiotic and refer. First dose antibiotic, stabilize the child and refer. So this we are obviously talking of the PHC level. If the child has come to a tertiary care hospital, you can of course admit and start antibiotics and supportive care. If there is chest indrawing or fast breathing is present, but no general danger signs, no danger signs, then the child is in yellow category. Yellow category means pneumonia is there, specific medical treatment is required. So you start oral antibiotics, okay, oral antibiotics, okay. Oral antibiotics, usually amoxicillin is started for 5 days, it is started, and you follow up after 2 to 3 days, okay. And if the child has got no signs of pneumonia, that means no chest indrawing, no fast breathing, no general danger signs, okay, then what do you do? We call it cough or cold or no pneumonia. So it is no pneumonia and cough or cold only. So you give home-based supportive care, right? And if you know the child is symptomatic for more than 14 days, you refer for evaluation of TB. If there is wheezing, you can start MDIs. If the saturation is less than 90%, you need to refer the child. So these are some also new things that have been added. Okay. Now coming back to our question. So here the child is having fever and cough. The child is otherwise active, playful, feeding well. So that means no general danger signs are there. So there is no general danger signs, no fast breathings, no general danger signs, no fast breathing, and no chest indrawing. So the child has what? No pneumonia, cough and cold only. So now let us see what is the management. So is it no pneumonia, symptomatic treatment and send home with warning signs? Yes, that is the best answer. It is not severe pneumonia as there is no general danger sign. It is not pneumonia as there is no fast breathing or chest indrawing. It is not very severe disease. So the best answer is A. So from any given case scenario, you can answer it. Okay? Confident? Right. Moving ahead. So in a 4-year-old child with idiopathic nephrotic syndrome being discussed in ward rounds, the interns want to inquire the indications when a renal biopsy will be indicated. So normally in a child, what is the most common cause? Okay, most common cause of nephrotic syndrome in a child is minimal change disease, we know, right? Minimal change disease. So in that, typically, you know, kidney biopsy is not required. Okay, so all of the following are recommended. All of the following are recommended indications for renal biopsy in childhood nephrotic syndrome except. So, you know, we will do kidney biopsy if you are getting some atypical features in nephrotic syndrome. If we are getting some features like nephritic syndrome or non-minimal change disease, only then we do kidney biopsy. Like severe hypertension. Is severe hypertension there in the criteria for diagnosis of nephrotic syndrome? No. What all are there in nephrotic syndrome? So there is massive proteinuria, generalized edema, hypoalbuminemia, and in addition hyperlipidemia is there, but it's not a diagnostic criteria. So severe hypertension is usually not a feature of nephrotic syndrome. So in this case we will do kidney biopsy. Deteriorating renal functions? No. Urea creatinine is usually normal in nephrotic syndrome. If there is deteriorating renal functions, we need to do a kidney biopsy. Massive proteinuria is just a part of the illness, nephrotic syndrome illness. So we need not do kidney biopsy in that. But persistent microscopic hematuria, if it is there, again it indicates a non-minimal disease. So in all the starred conditions, we are going to do kidney biopsy. But for massive proteinuria alone, we do not need kidney biopsy. Now, when do you call it massive proteinuria in children? It is very difficult to collect 24-hour urine sample in a 2 or 3 or 4-year-old child, right? They will obviously not tell you every time before peeing, or they'll just go and do it, not collect the urine. What do? You take a single morning spot sample of the urine and you do so for massive proteinuria, what you do is, you do a urine protein to urine creatinine ratio. Urine protein to urine creatinine ratio. So if this urine protein to urine creatinine ratio is more than 2, it indicates massive proteinuria. Okay? Or urine protein 3 plus or more is also taken as a surrogate, right? So most common cause of nephrotic syndrome in children already we have sorted out as a minimal change disease. Treatment of nephrotic syndrome, the initial episode, the treatment drug of choice is prednisolone. Okay, prednisolone. So, prednisolone, how do you give it in nephrotic syndrome? So, you give it as 2 mg per kg per day for 6 weeks daily, followed by 1.5 mg per kg alternate day for 6 weeks. Right? So, you give 6 plus 6 regime. That means for 12 weeks is the treatment required for the first episode of nephrotic syndrome. If there is a relapse, again the drug of choice is prednisolone, but we give it for a shorter time. We give it daily till remission and then alternate weeks for 4 days, for 4 weeks. Okay. So, daily till remission followed by alternate day for 4 weeks. SDNS or steroid dependent nephrotic syndrome. That means whenever you are tapering steroid or stopping steroid, relapse is happening. Okay. So, steroid dependent nephrotic syndrome, the drug of choice is low dose alternate day prednisolone. Okay, but then you can get a case scenario where there are features of steroid toxicity are developing. What are the features of steroid toxicity? Like Cushing syndrome is happening, or the child is developing hyperglycemia or diabetes, or hypertension or cataract. So, if any steroid toxicity is happening, then you cannot give this low dose alternate day prednisolone, you have to use steroid sparing agents. Now, those include, you can either use levamisole or you can use cyclophosphamide, okay, or you can use MMF. What is MMF? Mycophenolate mofetil. While in steroid resistant nephrotic syndrome, your drug of choice is calcineurin inhibitors. Calcineurin inhibitors, what are the examples of calcineurin inhibitors? Yes. So, we know they are cyclosporin and tacrolimus. Cyclosporin or tacrolimus you can use. Okay, right. Moving ahead, a 4-year-old male child with a body weight of 15 kg and height 100 cm admitted with renal failure. His blood urea was 100, creat was 1 mg per dl. What is the closest estimated GFR? GFR is glomerular filtration rate. The unit for GFR, as you can see, is ml per minute per 1.73 meter square body surface area. Now, to calculate the estimated GFR, yes, so Shivani is asking relapse prednisolone dose. So, the dose in relapse is also 2 mg per kg daily till remission, followed by 1.5 mg per kg alternate day for 4 weeks. Okay, right. So, estimated GFR we calculate using this Schwartz formula. It can be asked for you. So, Schwartz formula is what? Estimated GFR is K into height in centimeters divided by serum creatinine in milligram per dl. And the K or constant has a value of 0.413 in children. Okay. So, 0.4 let us take it. So, estimated GFR in this case will be, so it is K into height by serum creatinine K we said is 0.4. Height given in the question is how much? It is 100 centimeters and serum creatinine is 1 milligram per dl. Okay. So, height is 100, serum creatinine is 1. So, estimated GFR is coming as 40 and the unit we said is ml per minute per 1.73 meter square. So, B is the best answer here. Shreya, Ashish, Mantasha, Vishnu, very good. Okay. So, chances of febrile seizure recurrence are more for all of the following except. Let us discuss a little bit about febrile seizure. We come back to answer this question. Definition of febrile seizure. Febrile seizure is seizures in any child. So, it is not just fever plus seizures, let me tell you. So, it is seizures in a child and the age group is 6 months to 5 years. In a child 6 months to 5 years with significant fever. Significant fever meaning the temperature should be more than 100.4 degrees, greater than or equal to 100.4 degrees Fahrenheit. So, seizures in a child 6 months to 5 years age with significant fever without any evidence of CNS infection. So, meningitis can also be there. Fever plus seizures is there in meningitis also. That is not febrile seizure. Okay. So, without any evidence of CNS infection or meningitis. Okay. Types of febrile seizure, we know simple febrile seizure, complex febrile seizure. Simple is usually generalized tonic-clonic seizure, while complex febrile seizure can be focal. Simple lasts for less than 15 minutes, focal lasts 15 minutes or longer. Okay. And simple occurs only during an episode, once during an episode of fever, but complex can be frequent or multiple times. So, you can remember 3 F's in complex febrile seizure: focal, 15 minutes, frequent. Okay. Now, what are the factors increasing the risk of febrile seizure recurrence? So, factors increasing the risk of febrile seizure recurrence are age less than 1 year, duration of fever less than 24 hours. So, as soon as fever happened, the seizures happened. So, the chance of recurrence are more. And fever which was less, not very high, 38 to 39 degrees Celsius at the onset of seizures. Apart from that, family history of febrile seizures, epilepsy, complex febrile seizure, decay, male gender, low serum sodium are also some postulated risk factors associated. So, coming back to our question, chances of febrile seizure recurrence, yes, typical or atypical is same as simple and complex. Okay. So, chances of febrile seizure recurrence are more for all of the following except onset less than 1 year, more chance of recurrence. Fever for more than 24 hours, no, but fever for less than 24 hours, more chance of recurrence. Temperature between 38 to 39, more chance of recurrence. So, the best answer is this. What is the treatment of febrile seizure? Simple febrile seizure, you just have to abort the seizure if it lasts more than 5 minutes. Less than 5 minutes, nothing to be done. Keep the child nil per oral, make the child lie down in left lateral or recovery position. If it lasts for more than 5 minutes, you can use midazolam nasal spray, buccal or nasal midazolam. If the child has brought to the hospital, you can use IV lorazepam. Okay. Simple febrile seizure, no long-term anti-epileptics are required. You can just give intermittent prophylaxis with clobazam. But complex febrile seizure, sometimes you start anti-epileptics like valproate. Okay. So, moving ahead, ACTH injection is used in the treatment of which of the following? So, we know ACTH injection is the treatment of choice for West syndrome. Okay. Juvenile myoclonic epilepsy, usually we use valproate. Rolandic epilepsy, you can use phenytoin or carbamazepine. Lennox-Gastaut syndrome is a difficult to treat syndrome where multiple seizure types are there and you have to use multiple anti-epileptics like valproate, clobazam, and a lot of anti-epileptics may be required. Okay. West syndrome, what is it? So, West syndrome is basically a triad. Okay. So, West syndrome is basically a triad where 3 things are there. Infantile spasms, or they are also called salam attacks. So, baby will have attacks like this. So, you can get a video based question also where an infant is having attacks like this. So, infantile spasms, developmental delay and hips arrhythmia. What is hips arrhythmia? It is this chaotic pattern that you see on EEG. You cannot make the head or tail of it. So, this is the typical triad of West syndrome. Drug of choice, injection ACTH. If that is not there in the options, the next best answer, corticosteroids. And the drug of choice for a child with infantile spasms in tuberous sclerosis, if that is the question, infantile spasms in tuberous sclerosis, then your answer becomes vigabatrin. Okay. Tuberous sclerosis we know is a neurocutaneous illness which has got skin lesions typically like ash leaf macules can be there, shagreen patches, adenoma sebaceum and a lot of other findings. Okay. Good, Vishnu. So again another EEG here for you. So a 7-year-old boy presents with multiple daily episodes of sudden staring, unresponsiveness lasting very briefly 10 to 15 seconds, followed by immediate recovery. His teacher reports frequent lapses in attention during the class and EEG gives this pattern. So what do you see in the EEG on taking a closer look? So it is the typical 3 Hz spike and wave pattern. So this part, okay, this part you can see is a typical 3 Hz spike and wave pattern. Okay, that is diagnostic of childhood absence seizures. Very good. So childhood absence seizures, the drug of choice we know is you can either use ethosuximide or valproic acid, and it has got excellent prognosis with 80% remission by adolescence. So that is the best answer here. So this is a typical case of childhood absence epilepsy or absence seizures. Moving ahead to assertion reasoning type of a question. In INI-CET we expect such questions. So in a child with Sturge-Weber syndrome and intractable focal seizures. So Sturge-Weber syndrome leads to what? Intracranial calcification. You can get tram tract calcification. Okay, and you get, looking at the child, you have port wine stain of the face, right? Port wine stain of the face is there. Seizures are there. You can get ophthalmological findings like glaucoma and all. Okay. So Sturge-Weber syndrome, intractable seizures if they are there, we can consider functional hemispherectomy. That's true. So assertion is true. What about reason? So reason for that hemispherectomy you do, is this the reason? Sturge-Weber syndrome causes glaucoma. Yes, it causes glaucoma, we know that. Visual field defects can also happen, which can contribute to neurological morbidity. Of course, they can contribute to neurological morbidity also. But is this reason the correct reason for the assertion? No. So this is not the correct reason for the assertion, but these two statements individually are true. So both assertion and reason are true, but reason is not the correct explanation of assertion is the best answer here. As I can see, most of you have answered it correctly. So I can see Vishnu and Yatinder, okay, and Ashish Saini, Harichandan. So Mantasha, many of you have answered it correctly. So Sturge-Weber syndrome, as we already mentioned, you can get a image-based question also. There can be port wine stain of one half of the face, leptomeningeal or brain angiomas, and ocular or eye involvement. Okay. Moving ahead, you have a 2-year-old female who is brought with marked hypotonia and absent deep tendon reflexes. So it is a floppy child. Hypotonia, absent ETRs, genetic testing reveals a homozygous deletion in SMN1 gene. So this homozygous deletion in SMN1 gene gives me the diagnosis. What is the diagnosis? So our diagnosis here is spinal muscular atrophy or SMA. Okay. Which of the following is the most likely diagnosis and what is the preferred treatment? It is not Duchenne muscular dystrophy. Duchenne muscular dystrophy is usually seen in males and there is pseudo-hypertrophy of calf muscles. There is no hypotonia as such, usually not much. So Duchenne is not the answer. SMN gene deletion is the confirmatory diagnosis for SMA. So of course SMAs are the answer. So gene therapy with onasemno gene, AB parvovec. So it is the gene therapy which is mentioned here, which is also called Zolgensma, is the best answer here if eligible. Myotonic dystrophy, no. Here we are not getting feature of myotonia or delayed relaxation of muscles. Congenital myopathy also, no. So our best answer is B, SMA. A little bit more about SMA, which is a progressive muscular debilitating disease. So here what happens is it is of course inherited homozygous deletion in SMN1 gene or the survival motor neuron 1 gene on chromosome 5 long arm. Loss of motor neurons at spinal cord in the anterior horn cells mainly. So there is progressive muscle denervation and there is atrophy, weakness. So anterior horn cells are what is affected, and slowly there can be loss of motor function and ambulation, and the patient becomes wheelchair bound. So till the last decade only supportive therapy was there. What makes this important is now we have specific drugs available for treatment. So you have this Spinraza or nusinersen, but it has to be given only intrathecally. It can be given intrathecally. That means you have to do a lumbar puncture and from there you have to inject it, right? Just like we inject intrathecal methotrexate in the treatment of acute leukemia. Okay. Zolgensma is the gene therapy. Gene therapy is to be given only one time and it is given IV, intravenously. And Everesdi or Risdiplam is an oral drug which is now available, oral drug, but it is to be given long term, okay, at least 2 years minimum, okay. So these are the treatment options, newer drugs available for SMA. So let us discuss the newer drugs for DMD also here. So you have exon skipping oligonucleotides like Amondes 45, which is called Casimersen, Exondys. So DIS, we know it is the dystrophin gene mutation here, dystrophin gene. So most of the drugs for DMD will have this DYS, dis, because of the dystrophin in the name, right? So Amondis, Exondis, Vyondis, all these are newer drugs for DMD. They are exon skipping oligonucleotides. There's a gene therapy also recently available, Elividis. Again, this has this dis here. There are some anti-inflammatory agents. So corticosteroids usually slow down the progression of disease. So another anti-inflammatory corticosteroid which is newly available for this is Agamree or Vamorolone can be used, and a non-steroidal histone deacetylase or HDAC inhibitor, that is Duvizat or Givinostat. So these are some newer drugs which have come on the DMD frontier, may be asked for you. Okay. Moving ahead, a 1 year or 8-month-old boy was brought with some bony deformities. On examination, there was frontal bossing, wrist widening, knock knees. All of these, of course, we know are features of, so frontal bossing, wrist widening, knock knees, all these are features of rickets. Now, the question is asking if which of these is not a feature of vitamin D dependent rickets type 1. Which of these is, mind you, not a feature. Read the question very, very carefully. Don't jump and answer the question, because, you'll see that the first option is correct. You have read vitamin D dependent rickets, you will answer as first option. Please don't do that. When you read, you will see that some of the other options are also correct, and then you will see, oh, not is there in the question. So please don't do that. Read the entire question, read all the 4 options before answering. So a little bit about the vitamin D pathophysiology, mechanism, metabolism, and then we come back to answer this question. So you have the dietary vitamin D or sunlight. So all this is cholecalciferol, which is acted upon in the body by 25-hydroxylase enzyme in the liver to form 25-hydroxycholecalciferol. Then 1-alpha hydroxylase enzyme in the kidney acts upon it to make the 1,25-dihydroxycholecalciferol, which is the active form of vitamin D. It is also called calcitriol, okay, which acts on vitamin D receptors. Now, vitamin D dependent rickets, VDDR, there are 2 types, VDDR1, VDDR2. VDDR1 happens when this active form of vitamin D is not getting synthesized. So it can be due to deficiency of 25-hydroxylase or it can be due to 1-alpha hydroxylase deficiency. Any of these can cause VDDR type 1. So the active form of vitamin D is not getting formed. It is autosomal recessive in inheritance. But if you have 1,25-dihydroxycholecalciferol is getting formed, but there is resistance at the level of receptors. Resistance at the level of receptors is seen in VDDR type 2. VDDR type 2, you have resistance at the level of receptors. Okay. Now coming back to our question, the question is about VDDR type 1, that means the active form of vitamin D is not getting formed. So it is an autosomal recessive disorder, correct. There is resistance of vitamin D receptors, no, that is there in VDDR type 2, not in type 1. They have low levels of 1,25-dihydroxy vitamin D3, yes, the active form of vitamin D is not getting formed, so low levels, okay, correct. Usually present during the first 2 lives, yes, it is a genetic disorder, autosomal recessive inheritance, of course it will present early on in life usually. So our best answer here is option B, okay, get it? So I can see many of you have answered it correctly, so proud of you, good job. So moving ahead, which of the following investigations are indicated in a baby found to have a TSH 70 on newborn screening? By heel prick sample obtained as dried blood spots at 80 hours of life. So TSH, if it is more than 20, then we take it as screen positive, okay. Whenever you get a positive screening, okay, positive screening for congenital hypothyroidism, you can either do a cord blood screening or you can do a heel prick screening. If you do heel prick, you usually take the sample beyond 48 to 72 hours to avoid the TSH surge which happens just after birth, okay. So if the TSH is more than 20, you do not simply label the child as congenital hypothyroidism. What do? You have to reconfirm. So you can reconfirm from the same sample, you can re-punch a different hole in the sample and reconfirm it, or you can recall them. Okay, and recall the patient and take a fresh venous sample, take a repeat sample. Take a repeat venous sample and you do the T3, T4, TSH in that. Okay, you do the T3, T4, TSH to confirm. Once it is a confirmed case, once you confirm that it is a confirmed case of congenital hypothyroidism, then what do? We have to find out what is the etiology, because then only we can decide whether it is permanent or temporary congenital hypothyroidism. How do you know the etiology? So very good, I can see Yatinder answering. So you must do both a USG thyroid gland to see whether the thyroid gland is present or not and is structurally normal or not. Plus you need to do a thyroid scan, the radionuclide scan, to know whether any dysharmonogenesis is there or not. So all these must be done. Okay, and of course the treatment is levothyroxine. We know that. Now, and the earlier you start the treatment, the better the child is. You can, prevent intellectual disability or mental retardation. You can ensure normal growth and all that. So what do you do next? Okay, the question is telling that which of the following investigations are indicated in this baby who is screened positive for congenital hypothyroidism, more than 20, right? What do? Reconfirmation by serum sample only? No. Reconfirmation by serum sample only? Yes. Followed by USG thyroid and thyroid nuclear scan if the baby is found to have congenital hypothyroidism is the best answer. Reconfirmation by serum sample only and USG thyroid gland alone will not help. You must do both ultrasound thyroid and thyroid scan in all the babies found to have congenital hypothyroidism. Further investigations not required, start the treatment of course is not the correct answer. So B is the best answer. As I can see, most of you have answered it correctly again. Good job. Okay. Moving ahead, a 10-year-old presents with polyuria, polydipsia and 15% weight loss over 2 weeks. What bells ring in your mind? Blood glucose 450, you have hyperglycemia also, pH is 7.25 meaning metabolic acidosis, bicarbonate is 12, ketones is positive. What is the initial priority in management? So what is your diagnosis here? Waiting for your replies. Yes guys, what is your diagnosis here? Yes. I can see you answering correctly, but first give me the diagnosis. So the diagnosis of course here is DKA or diabetic ketoacidosis. A little bit let's discuss, then we come back to answer this question. Okay. How do you diagnose DK in children? There has to be hyperglycemia, blood glucose more than 200, venous pH less than 7.3 or serum bicarbonate less than 18, ketonemia or ketonuria. So all these three must be present to call it DKA. Here we have glucose more than 200, we have pH less than 7.3 and we have ketones also positive in urine. So it is DKA. You have to decide the severity. If pH is less than 7.1 or bicarb less than 5, it is severe DKA. You assume 10% dehydration. Moderate DKA, pH is 7.1 to 7.2, bicarb 5 to 10, it is moderate case, 7% dehydration. Mild DKA, pH 7.2 to 7.3 and bicarb 15 to 18, 5% dehydration, mild DKA. Now, insulin therapy in DKA. Okay, in any child with DKA, the first thing we do is in management is, of course, after the initial stabilization, airway, breathing, circulation, start IV fluids. So we start IV fluids. So usually we use normal saline. So we start IV fluids in the first hour. First hour, give IV fluids only, no insulin. Then what do? Then we start insulin. We use regular insulin. Infusion. Okay, we do not get stat dose or bolus dose. Okay, when to start? 1 hour after starting IV fluids. Okay, to prevent cerebral edema, which is a life-threatening complication. The dose is 0.05 to 0.1 unit per kg per hour. Okay. Coming back to our question. So, what is the initial priority in management? Stat dose followed by regular insulin infusion. Will you give a stat dose of insulin? No. Infusion of regular insulin 0.05 to 0.1 to be started after 1 hour of starting fluid is the best answer. Bolus subcutaneous insulin given? No. Insulin as per mixed split or basal bolus? No. So our best answer is you start fluids, 1 hour later start insulin infusion in the given dose, right? So moving ahead to our next question, we have a 10-year-old boy with SMR 5. SMR 5 is what? Sexual maturity rating 5 is seen in a mature adult. If you are getting it in a 10-year-old child, means the child has precocious puberty. Yes? Precocious puberty. So guys, please focus. These are the most important topics for your upcoming INI-CET exams. Yes, the admit card, the city has come. You can check it after the class. Let us focus now and give our best and take our best for our upcoming exams. Okay. So BP is 150 by 90. That means definitely there is hypertension and hypertestosteronism. What is the enzyme deficient? So here we are possibly dealing with a case of congenital adrenal hyperplasia. Yes. So let us first discuss a little bit about CAH. We come back to answer this question. The most common cause of CAH, of course, is 21 hydroxylase deficiency. What happens in that? So you remember the enzymes here are 3, 21, 11. 3, 21, 11. That means 3 beta hydroxysteroid dehydrogenase, 21 hydroxylase and 11 beta hydroxylase. Okay? Right? And the first pink pathway is the mineralocorticoid pathway, next is the glucocorticoid, and next is the sex steroid pathway. Now, if the 21-hydroxylase enzyme is deficient, what is happening? The mineralocorticoid pathway not happening, the child goes in shock. Glucocorticoid pathway not happening, the child again has shock, dehydration, and because no mineralocorticoid, there is hyperkalemia. Okay, sodium is not getting absorbed, potassium is not getting excreted. But excess of sex steroids are formed. So, what will happen? There will be ambiguous genitalia in a female. Ambiguous genitalia in a female. But what will happen in a male? Male will have normal genitalia even if excess of testosterone. But when this male grows up, there will be precocious puberty. But will there be hypertension? No. There will be shock, dehydration, no hypertension. So, this is not the right answer. Okay. So, most common cause of CAH, most common cause of ambiguous genitalia in a baby of course is CAH. Most common cause of CAH is 21-hydroxylase deficiency that we just discussed. Okay. And screening for CAH can be done using. So, this screening we do using this metabolite which is elevated, that is 17-hydroxyprogesterone. So, screening is done using 17-hydroxyprogesterone. We can do newborn screening. Okay. Now, what happens in 11-beta-hydroxylase deficiency? Again, remember the sequence of enzymes 3, 21, 11, 3, 21, 11. So, here is the deficiency. What is happening? Mineralocorticoid pathway not getting completed, but excess of deoxycorticosterone is formed, which has mineralocorticoid activity. Excess of sodium water absorbed, so there is hypertension. Okay. Okay. And excess of 11-deoxycortisol is formed, no features of steroid deficiency, no shock. Now, because these pathways are not getting completed, excess of sex steroids are formed. So, again, female will have an ambiguous genitalia. Okay. While a male will have normal genitalia. Male will have normal genitalia, but when this male grows up, there will be precocious puberty. So, precocious puberty in a male with hypertension, we think of 11-beta-hydroxylase deficiency as is the case in the given question. So, that is the best answer. What happens in this 3-beta-hydroxysteroid dehydrogenase deficiency? So, it becomes a cakewalk if you understand it. Develop your concepts well. So, see, here again the sequence of enzyme is 3-21-11, 3-21-11. And this 3-beta-hydroxysteroid dehydrogenase enzyme is common to all the three pathways, the glucocorticoid, mineralocorticoid and sex steroid pathway. So, no mineralocorticoid form, no glucocorticoid form. So, there will be shock, there will be hyperkalemia, dehydration, hypoglycemia and sex steroid also not formed. In the absence of sex steroid, the default genitalia is female. So, there will be an under-virilized male, but female will have a normal looking genitalia. But at puberty, what will happen? There will be no pubertal changes in the female because sex hormones are not there. So, that is what happens in 3-beta-hydroxysteroid dehydrogenase deficiency, right? And what happens in 17-alpha-hydroxylase deficiency? Ajju, I am coming to it. So, 17-alpha-hydroxylase is this enzyme, right? So, what will happen? Excess of mineralocorticoids are formed. So, there is hypertension here also. But what will happen again? This glucocorticoids and sex steroids are not getting formed. In the absence of any sex steroid, what will happen to the genitalia? The default genitalia will be female. So, in a karyotypic male, genotypic male, what will happen? Ambiguous genitalia. So, it will be an under-virilized male and female will have a normal genitalia but delayed puberty or absent puberty changes. Okay, there will not be precocious puberty at all. So, that is why this is not the answer here. Ajju, are you getting it? So, because sex steroids are not getting formed in 17-alpha-hydroxylase deficiency. So, let us summarize. Ambiguous genitalia in a female with shock, you think of 21-hydroxylase deficiency. Okay, ambiguous genitalia in a female with hypertension, we think of 11-beta-hydroxylase deficiency. And in a male, of course, it will not cause ambiguous genitalia. In a male, it will be precocious puberty when the male grows up. Okay. Right? And if it is an under-virilized male with shock, we think of all three pathways affected. So, 3-beta-hydroxysteroid dehydrogenase deficiency. Under-virilized male with hypertension, we think of 17-alpha-hydroxylase deficiency. I hope it is clear to all of you now, right? Moving ahead. So, a term newborn is delivered after prolonged second stage of labor, 60 seconds, the infant has a heart rate of 80 per minute. Wherever in neonatal resuscitation, heart rate less than 100 per minute, what will you do? positive pressure ventilation. Okay. So what was done? So gasping respiration was there, central cyanosis was there, some flexion of extremities were there, positive pressure ventilation started with 21% oxygen and for 30 seconds. But there is no improvement even on positive pressure ventilation. If no improvement on positive pressure ventilation, what will you do? You will take ventilation corrective steps, right? So ventilation corrective steps, what are they? So ventilation corrective steps are MR SOPA. So that is mask. So you have to mask readjustment. Okay, you have to readjust the mask. You have to position the airway. You have to do suction. Okay, and you have to increase the pressure, open the mouth, and you have to use alternate airway. Okay, so if there is no improvement, will we increase FiO2 100% and continue PPV? No, we will not increase FiO2. But what else can we do? So you can endotracheal intubation with surfactant. Surfactant is not required in a term baby. It is a term newborn. No surfactant, right? Chest compressions, no. We do chest compressions only if the heart rate is less than 60 per minute. No. So check mass seal and increase inflation pressure. So this is the best answer. So you will take ventilation corrective steps. Okay. Now, very recently, just a week back, latest 2025 guidelines of neonatal resuscitation have come, which are almost similar to our previous guidelines. I'll just quickly tell you a couple of changes that have been there. So this is the latest 2025 neonatal resuscitation guidelines that has just come almost a week ago in October only. Okay. So what new things have been added? INICET cord management plan has been added. This all antenatal counseling, team briefing, equipment check remains same. So INICET cord management plan has been added, and it has been now mentioned that delayed cord clamping you have to delay for at least 60 seconds. Previously it was 30 to 60 seconds, at least 30 to 60 seconds. Okay. What else? So then term gestation, good tone, breathing or crying, all that is same. Now in the next step, warm. So initial steps, warm and maintain normal temperature, dry position, stimulate and clear airway if needed is there. Suction is not mentioned separately, just clear airway if needed is mentioned. And here instead of positive pressure ventilation, now they have just mentioned the word ventilate. So essentially the neonatal resuscitation guidelines have remained the same. There is no change in the practice as such. The only few things that have been mentioned is INICET cord management plan has been added, at least 60 seconds have been mentioned. Ventilate instead of positive pressure ventilation they have mentioned, and 30 to 60 per minute is the rate of positive pressure ventilation that has been mentioned. And in the target oxygen saturation they have removed the 1 minute. Okay, 1 minute 60 to 65% was there. Now they have just started it from 2 minutes. And one more change in the guideline is the oxygen to be used during resuscitation. In a term newborn, of course, we start with room air, even if we are doing positive pressure ventilation. 32 to 34 weeks, saturation oxygen concentration of 21 to 30% is recommended. Less than 32 weeks, you can even use more than 30%. So these are the latest changes in the October 2025 guidelines of neonatal resuscitation. So this, of course, is a self-inflating bag and a mask. We know it is a self-inflating bag. Okay, self-inflating bag. This is the mask and a tight seal is required. This is the oxygen tubings, this is the reservoir. What is the function of the reservoir? The function of the reservoir is to increase the FiO2 delivered to the baby, increase the fractional concentration of oxygen in the inspired air. PPV is required at the rate of 30 to 60 breaths per minute. Okay, and an absolute contraindication of positive pressure ventilation, of course, is this, which is a spotter, has come multiple times, can come again definitely. So this is a typical X-ray showing congenital diaphragmatic hernia, which is an absolute contraindication. Absolute contraindication for congenital diaphragmatic or for bag and mask ventilation. Okay, bag and mask ventilation. So Vishnu is asking pop-up valve at what pressure? So pop-up valve you can set. Usually for newborns, pressure beyond 40 to 50 centimeters of water, it will, pop-up valve will release the pressure, because we don't want to give a higher pressure than that, it can cause pneumothorax. So absolute contraindication of bag and mask ventilation is CDH. So congenital diaphragm, you can see here the spotter. You can see bowel gas shadows in the thorax, you can see mediastinal shift, heart shadow has moved here, and you can see hardly any lungs, so pulmonary hypoplasia. Okay. Now ratio of chest compression is to positive pressure ventilation, very important in neonatal resuscitation. We know it is 3:1 and nothing else, please remember. But in PALS guidelines for an older child, we are not talking about neonate, then the resuscitation, if it is 1 rescuer, the ratio becomes 30:2. If it is 2 rescuers, the ratio becomes 15:2. Okay, we'll remember, right? Moving ahead, free flow oxygen can be given in a neonate by all except. So let us see what are the methods by which we can give free flow oxygen to a neonate. So we can give it using oxygen tubing like this directly. We can give it using a mask, but we will not make a seal with the face. If we make a seal, then it becomes positive pressure ventilation. We don't want to do that. We can give it using a T-piece, and we can give it using the reservoir of a self-inflating bag or a mask. Okay. So these are the ways of giving free flow oxygen to a neonate. So free flow oxygen can be given to a neonate by all except mask of a self-inflating bag, no, because that will cause a tight seal and positive pressure. We don't want to give that. Tail or reservoir of self-inflating bag and mask we can give. Face mask over mouth and nose we can give oxygen. Tubing over mouth and nose we can give. So the best answer is this. A. Mask with a self-inflating bag we do not use to give free flow oxygen. Okay, because positive pressure will also be delivered with that. Okay. Moving ahead, a term newborn was found to be small for gestational age. Okay, small for gestational age, which of the following hormones is not involved in the growth of fetus? So, insulin, growth hormone, thyroxine, glucocorticoids. So, we know in the fetal life, insulin, thyroxine, glucocorticoids all play a role in growth, but growth hormone does not. Okay, so growth hormone is the best answer here. And how do we get that evidence? Because even if a baby has growth hormone deficiency, at birth what will you find? At birth we will find that the weight and length of the baby is normal. That means in intrauterine life, the baby's weight or growth is not affected by the growth hormone, right? So it will usually present with short stature, obesity later in life. The upper segment, lower segment ratio, what will happen to growth, them in growth hormone deficiency? It will remain normal. Why normal? Because, growth hormone deficiency is one of the causes of proportionate short stature. Bone age will be less than the chronological age because there is delayed skeletal maturation, okay, in growth hormone deficiency. Investigation, what will you do? We do growth hormone stimulation test. One time value of growth hormone level is not useful because of the pulsatile secretion. So, if you do a growth hormone stimulation test and the peak growth hormone values are less than 10 nanogram per ml, that is diagnostic of growth hormone deficiency. For the management, you have recombinant growth hormone injections available. Recombinant growth hormone injections are available. One of the side effects of growth hormone therapy is pseudotumor cerebri, hyperglycemia, slipped capital femoral epiphysis, and so on. What dose of dexamethasone is given to a pregnant lady presenting at 30 weeks gestation anticipated to go in preterm labor for fetal lung maturity? So, let us discuss a little bit about antenatal corticosteroids. We come back to answer this question. So, which antenatal corticosteroid is to be used? So, we can use either betamethasone or dexamethasone. Now, betamethasone is, is better, less side effects, but dexamethasone is cheaper, more easily available. So, Indian guidelines favor dexamethasone. Okay. Both have almost equal efficacy. The dose is always asked. So, betamethasone, the dose will be 12 milligram, 2 doses, 24 hours apart. 12 milligram, 2 doses, 24 hours apart. So, the total dose you can remember is 12 into 2, that is 24. Dexamethasone, the dose is 6 milligram, 4 doses, 12 hours apart. Again, the total dose is same, that is 6 into 4 is equal to 24. Okay. Now, antenatal corticosteroids are to be given to all pregnant ladies expected to deliver. So, expected to deliver between 24 to 34 weeks gestation, then we give it. Okay. Mainly to accelerate the fetal lung maturity. Contraindication, if there is a feature of chorioamnionitis or if we are suspecting infection, obviously we will not give steroids. Okay, chorioamnionitis. Beneficial effects, why do we want to give antenatal steroids? Because it decreases the risk of respiratory distress syndrome, it decreases the risk of intraventricular hemorrhage, decreases the risk of NEC or necrotizing enterocolitis, and overall decreases neonatal mortality in preterm neonates. Okay. So, that is why we want to give antenatal steroids. Okay. So, moving back to our question, the dose of dexamethasone given to a pregnant lady at 30 weeks gestation, anticipated to go in preterm labor for fetal lung maturity. So, the dose we give will be what? So, dexamethasone hai, so it will be 6 milligram 4 doses 12 hours apart. Okay. So, 6 milligram 4 doses 12 hours apart. So, we are almost more than we have covered more than 50% of our session. We will take a quick bio break of 5 minutes and we will resume in 5 minutes. Okay. So, the time is 7:45 by my watch now. We start again at 7:50. So welcome back. Let us move on to the next question. Can someone give a quick confirmation if you can see my screen and if I am audible so that we can resume? Waiting for your reply. Please confirm if you can see me, hear me, see my screen so that we can start. Thank you, Vishnu. Okay, so we are good to go. So which of the following are components of the Downey score? So Downey score is a score which is used in term neonates to quantify respiratory distress. Okay, let us see what all are the components. We come back to answer this question. So all these scores, Downey score, Silverman score, Apgar score, they have a scoring of 0, 1, 2 and 5 components. Okay, so Downey score, the components are cyanosis, retractions, grunting, air entry and respiratory rate. So don't worry, you will get annotated handouts or PDFs of this session after this session. So don't bother to write. But the components are cyanosis, retractions, grunting, air entry and respiratory rate. All of them you give a score of 0, 1 or 2. So you can see more the severity, more is the score. Like cyanosis, no cyanosis, we give a score of 0. In room air, we give it a score of, in room air, we give it a score of 1 and in 40% FiO2, we give it a score of 2. Similarly, retractions, none, mild, severe. Grunting, none, audible with stethoscope, without stethoscope and so on. So, more the severity, more the score. So, score of more than 7 would indicate severe respiratory distress. So, you need not know the score in detail, but at least the components you need to know. So, cyanosis, retractions, grunting, air entry and respiratory rate. So, coming back to our question, respiratory rate is a component. Feeding you can see is not a component. Grunting and cyanosis are the components. Okay. So, the best answer is the option with 1, 3 and 4, that is option B. Good. Vishnu, Yatinder, right? Yes, just like Silverman. Apgar score, let's discuss it here also. So, Apgar we know is an acronym. A stands for appearance. Okay, you may be given a case scenario, may be asked to do the Apgar score. P stands for pulse rate. G stands for grimace, that means what is the response to stimulation by a catheter. A stands for activity and R stands for respiration. Okay, respiration or respiratory effort and not respiratory rate. Each of them given a score of 0, 1, 2. Appearance, if completely blue or pale, we give it a score of 0. Body pink, extremities blue, 1. Completely pink, 2. Pulse rate absent 0, less than 101, more than 102. Grimace, no response, 0. Grimaces 1, 2 we give it when the baby coughs or cries on stimulation. Activity, limp and flaccid 0, some flexion 1 and well flexed, well moving limbs 2. Respiration or respiratory effort absent 0, slow and irregular 1 and good respiratory efforts 2. So you can see more the Apgar score, better it is. So more than 7 would be normal. And less than 3 Apgar score will indicate a severely depressed baby, not the psychiatry wala depression, of course, severe birth asphyxia. Okay. Very good. Respiratory rate is not a component, but respiration or respiratory effort is. And Apgar score, remember, has no role in neonatal resuscitation. It just has a prognostic value. Silverman score again is a component which it is a score with 0, 1 and 2. It is used to quantify respiratory distress in preterm neonates. Respiratory distress in preterm neonates. Okay. So again, the components are simple to remember: upper chest retractions, lower chest retractions, episternal retractions, and you have nasal flare and grunt. Each of them 0, 1, 2. And more the Silverman score, more is the distress. So again, more than 7 indicates severe respiratory distress. Okay. So that is the Silverman score used in preterm neonates. Now, a newborn baby delivered at 36 weeks of gestation was found to have respiratory distress soon after birth. Baby required FiO2 of 30%, that means not very high oxygen requirement, chest x-ray shown. What is the most likely diagnosis? So, you can see the chest x-ray is almost normal. You can just see some fluid in the interlobar fissure that is there and some prominence of bronchovascular markings. And it is almost a near term baby. Term baby is more than 37 weeks of gestation. This baby is 36 weeks, near term baby. Not much respiratory distress, fluid in an interlobar fissure. So, our diagnosis of course is transient tachypnea of newborn. Let us discuss the options one by one. So, discussing the options one by one. So, respiratory distress syndrome is a disease of preterm neonates. Okay, preterm neonates due to the deficiency of surfactant. Okay, deficiency of mature surfactant. and it is usually seen at less than 35 weeks gestation. Function of surfactant is to decrease the surface tension of alveoli. If there is deficiency of surfactant, what will happen? The alveoli will collapse. Now, alveoli are collapsing means alveoli contains less air. Why do lungs appear black on X-ray? Because of the air. If less air, what will happen? Ground glass haziness of lungs, like you can see here. And presence of air bronchogram, because no problem in the bronchus bronchioles, there is air in them. So this is what you typically get. You can get features of lung collapse also, right? So that is respiratory distress syndrome or hyaline membrane disease, and to treat it, mild cases CPAP or continuous positive pressure airway alone. Moderate to severe cases you need to give surfactant. There are some ways to give surfactant. You can use insure, that means intubate, give surfactant, extubate. There are some newer methods like LISA, which is less invasive surfactant administration, or MIST, minimally invasive surfactant therapy. So these are the newer terminologies. Transient tachypnea of newborn we already discussed. So it is basically due to delayed clearance of lung fluid. Okay. And delivery by cesarean section is a risk factor. Delivery by cesarean section is risk factor for this. Okay, and it is usually a self-limiting illness. Distress subsides on its own. No treatment is required. Okay. Meconium aspiration syndrome, what happens? Meconium goes into the airways. You can have hyperinflation. You can have hyperinflated lungs. You can have chemical pneumonitis. And in the baby, you can have increased anteroposterior diameter because of the air trapping. Okay, you can see the infiltrates because of the chemical pneumonitis. So you will get a history that the baby is born through meconium stained liquor and develops respiratory distress soon after birth, right? Neonatal pneumonia, of course, you can get a patch here, you can get a sepsis-like picture. The investigations can show you sepsis screen positive, procalcitonin high, baby can have respiratory distress and so on. Mother can have leaking PV and features of infection as well. Moving ahead, a premature infant born at 28 weeks of gestation develops respiratory distress and increasing oxygen requirement on the 10th week of life. So, baby has prolonged oxygen requirement, okay, 10th week of life. So, chest X-ray, so prolonged oxygen requirement can cause two problems. It can cause a lot of problems, but mainly two. One is ROP, retinopathy of prematurity. Another is chronic lung disease or bronchopulmonary dysplasia. So, chest X-ray shows diffuse bilateral infiltrates. Most likely diagnosis, as I mentioned, of course, it is bronchopulmonary dysplasia. It is not pneumothorax. In pneumothorax, baby will not have problem for 10 weeks. If it is severe pneumothorax, the baby will succumb to it, and otherwise mild can resolve spontaneously. Pneumonia antibiotics, again we are not expecting that with pneumonia the baby will have oxygen requirement for 10 weeks. Patent ductus arteriosus, again the baby can have patent ductus arteriosus, but then infiltrates on the lungs will not be there, and in a preterm baby patent ductus arteriosus will manifest much before 10th week, right? So the best answer here is bronchopulmonary dysplasia, optimize ventilation. Yes, RDS and mass X-rays look similar, but I will just show you once again. See, respiratory distress syndrome, you have a diffuse ground glass haziness of lungs, okay. You can see a diffuse ground glass haziness of lungs that is there, and there is presence of these air bronchogram. But in meconium aspiration syndrome, there was hyperinflation, okay. So, the lungs are hyperinflated here. You can see flattening of the domes of diaphragm, and you can see some infiltrates. There is no diffuse haziness. It is more patchy, okay, and heterogeneous, and there is hyperinflation, while in respiratory distress syndrome it is low volume lungs, okay, and plus the scenario will help you distinguish also. So, this bronchopulmonary dysplasia is also known as chronic lung disease, okay, chronic lung disease, okay, and it is due to atelectotrauma, barotrauma, volutrauma. So, this ventilation, oxygen, all this causes injury to the lungs, and that causes bronchopulmonary dysplasia. How do you define it? So, BPD is defined for babies born at less than 32 weeks of gestation who require oxygen for at least first 28 days or 4 weeks of life, and they are assessed at 36 weeks post menstrual age, okay, from the LMP if you count. Treatment of BPD, mild BPD, no supplemental oxygen required. Moderate BPD, oxygen required at less than 30%. So, it is basically the categorization. It is not treatment, it is the categorization of BPD. So, oxygen requirement at more than 30% or CPAP or mechanical ventilation, we call it severe BPD. BPD is very difficult to treat entity. Supportive care is what makes the difference. Vitamin A, steroids and all have also been studied in management. Okay. Choose the correct option about physiological jaundice of newborn. Read the options very carefully. First, let us discuss about physiological and pathological jaundice. We come back to answer this. Okay. So, physiological jaundice. never appears. So, clinical jaundice or icterus never appears in first 24 hours of life in physiological jaundice. But pathological jaundice may appear in first 24 hours. Physiological jaundice is never very severe. So, palms and soles not yellow. Okay. If palms and soles are yellow means it is severe jaundice, it is pathological. Now, physiological jaundice is always unconjugated. Always unconjugated. If it is conjugated bilirubin, how will you know? Conjugated will have yellow urine or high colored urine, and pale stools can also be there. High colored urine if it is there, or pale stools if it is there, then it is not physiological jaundice. And physiological jaundice usually does not persist beyond 3 weeks. So, does not persist beyond 3 weeks, okay, beyond 3 weeks. But pathological jaundice may persist for a longer time. So, now coming back to our question. So, baby may appear icteric in the first 24 hours in physiological jaundice? Never. It is always, so you have to find the correct options. It is always unconjugated is correct. Urine is yellow and stools are pale in physiological jaundice? Never again. Palms and soles are not stained yellow is correct. So, 2 and 4 are correct. So, option C is the best answer. I can see already Yatinder, Vishnu, Mantasha, Invisible, Harsing. So, breast milk jaundice usually again comes in physiological jaundice only. I will be coming to breastfeeding and breast milk jaundice. So, breastfeeding jaundice is due to inadequate breastfeeding. What happens is a state of relative dehydration and relative polycythemia, so high bilirubin levels. What is the treatment? Frequent breastfeeding. Frequent breastfeeding. So, these breastfeeding and breast milk jaundice are diagnosis of exclusion only. Breast milk jaundice, what happens? Due to substances present in breast milk like pregnenolone and free fatty acids interfere with the conjugation of bilirubin. So, unconjugated bilirubin level is only rising, so it is like physiological jaundice only. Usually, no treatment is required, breastfeeding is continued unless the bilirubin level becomes more than 20. Only then we temporarily withhold breastfeeding. Otherwise, usually no treatment is required. Okay. What is the treatment of choice for neonatal jaundice? So, it is phototherapy. So, you can see baby kept under a blue light and the baby's eyes are covered because it can cause retinal toxicity. Baby's genitalia is also covered because it can cause gonadal toxicity. So, this most effective wavelength for phototherapy is 450 to 460 nanometer. You can choose any range that includes this range like 430 to 490 or 425 to 475 nanometers. There are 3 mechanisms of action: photoisomerization, structural isomerization, photooxidation. Of these, the most important is structural isomerization. By this method, what happens? The bilirubin is converted to lumirubin, which can be excreted through kidneys without conjugation. And this is an irreversible process, making it most important. Effectiveness of this phototherapy depends on the distance between the baby and phototherapy unit. If you keep the phototherapy unit closer to the baby, it is more effective. If the exposed surface area of the baby is more, then it is more effective, and LED lamps are better than CFL lamps and less interruption will make it more effective. It does not depend upon skin pigmentation, of course. Okay. So physiological jaundice, yes, 11 milligram per dl comes under physiological only, pathological, but then again you have to see in the context of what is the age of the baby. We have graphs from which we can determine the values to answer your question, right? Adverse effects of phototherapy, they can be bronze baby syndrome, the color of the baby's skin darkens temporarily, that is bronze baby syndrome. There can be diarrhea, dehydration, impaired maternal child bonding, hypocalcemia, and as we saw, retinal or gonadal toxicity can be there. Okay. Now coming to the cutoffs, coming to your question, Vishnu. So, usually actually what we do is we use graphs, we plot that at this hour of life bilirubin is this, so phototherapy is required or not. If this hour of life bilirubin is this, exchange transfusion required or not. But to tell you some rules of the thumb. So, in otherwise well healthy term neonate, that means no RH incompatibility, no sepsis, no preterm neonate, then at 24 to 48 hours of life, if bilirubin is more than 15, then we do phototherapy. At 48 to 72 hours life, if it is more than 18, beyond 72 hours only if bilirubin is more than 20, you need phototherapy. For exchange transfusion, the cutoffs are 20, 25 and 25. Okay. But you will be surprised to know, if a baby has RH incompatibility, or erythroblastosis fetalis, then exchange transfusion is required if the cord blood bilirubin is more than 5. Cord blood bilirubin is as low as 5 milligram per dl. Then also exchange transfusion is required, more than 5 milligram per dl. Okay, right? Which of the following is true about cephalhematoma? So let us discuss about cephalhematoma and caput and we come back to answer this question. Okay. So did we answer our previous question? Yes, we did. Okay. So cephalhematoma and caput succedaneum. What is cephalhematoma? Name itself is telling you it is a hematoma or collection of blood. Yes. So cephalhematoma is basically subperiosteal hemorrhage involving cranial bones. Okay, but caput succedaneum is nothing but edema in the layers of scalp, nothing to do with bone or periosteum. Edema in layers of scalp. Cephalhematoma, because each bone has its own periosteum, periosteum is not continuous over two bones, so it does not cross sutures, but caput succedaneum can cross sutures. Cephalhematoma takes time to appear also, disappear also. So cephalhematoma may take 24 to 48 hours to appear completely, disappears in 5 to 7 weeks or even longer. And it predisposes to neonatal jaundice because it is a collection of blood. Blood means hemoglobin breaks down to heme delivered in bilirubin. What about caput? It appears at birth, it is already present if it is there in maximum size, disappears in 48 to 72 hours and it does not predispose to jaundice. So these are the basic differences. Now another hemorrhage which is much more severe than that is subgaleal hematoma, where you can get a diffuse bleeding, the baby can have features of shock, baby can appear pale and you can see a large area of bleed in the scalp. So that is subgaleal bleed. Okay. So most severe, if you ask which of the bleeds is for the baby, it is the subgaleal bleed. Okay. So which of the following is true about cephalhematoma? Let us answer. Its size is maximum at birth, is it? No. It may take 24 to 48 hours to appear completely. We have to find the true statement. It resolves in 7 to 10 days? No. It takes 5 to 7 weeks to disappear. It is limited by periosteum? Yes. It is a periosteal hemorrhage. It is due to edema in the layers of scalp? No. That is caput. So our best answer here is option C. Clear? Are we good? So this is what is it? Tell me. So this is a cephalhematoma. You can see between the bone and its periosteum, this is the collection of blood. It is not crossing the sutures. Okay. Alternate way to measure height in a 4-year-old child. So head circumference, will it give clue about the height? No. Knee height again will not tell you about the entire height of the child. Crown rump length. What does crown rump length tell you about? Waiting for your replies. I am not answering it right now. But arm span, yes, is the correct answer. It is almost equal to the height. The difference between height and arm span is less than 3 centimeters usually. So this is how you calculate the arm span. So you ask the child to outstretch the hands and from the tip of one middle finger to the tip of other middle finger, you measure the arm span. It is almost equal to the height. And you know there is upper segment lower segment ratio also, and this is the sitting height which gives you the upper segment. Okay, right? Now what is the upper segment lower segment ratio normally at different ages? At birth it is 1.7 to 1.9 is to 1. Yes, I can see all of you answering correctly. 3 years it is 1.3 is to 1, 7 to 10 years it becomes 1 is to 1. Okay, beyond that it can become even 0.9 is to 1. So, what is the normal rate at which head circumference increases? Also asked once. First 3 months of life, it increases at the rate of 2 centimeter per month. Next 3 months, 1 centimeter per month. Next 6 months, 0.5 centimeters per month. And next 2 years at the rate of 0.2 centimeter per month. So, never in the life of a baby, you can see in any given month, the head circumference can increase by more than 2. If the head circumference increases by more than 2 centimeter in any month, then it is abnormal. You have to look for underlying hydrocephalus, bleed or any other cause. Okay. And yes, all of you have answered it correctly. So, crown rump length is used. It is an ultrasound parameter used in first trimester. It is the most accurate method for assessing gestational age of a fetus. Okay. Right. So, you can see this is the crown rump length. Okay. Moving ahead, you have a 9-month-old infant who is brought to the pediatrician with a concern that 9 months the child cannot sit without support. The child is otherwise able to roll over, says mama dada, waves bye bye, has strange anxiety. Which of the following is the most appropriate management? Before answering this question, let us do a quick recap of the developmental milestones, important ones, then we come back to answer this. Neck control. Partial neck control comes by 3 months, complete by 5 months. Sitting with support comes by what? 6 months, right? Sitting without support by 8 months. Standing with support by 9 months, standing without support by 12 months. Walking with support by 12 months, walking without support by 13 months, and rides a tricycle at 3 years, very, very important. Okay? So, fine motor holds an object when placed in hand at 3 months, reaches out for objects at 4 months. Bidextrous grasp holds with both hands at 4 to 5 months. Palmar grasp or unidextrous grasp at 6 months. Now, transfers objects from one hand to another at 7 months. Immature pincer grasp 9 months, mature pincer grasp 12 months. Scribble spontaneously. So, this is scribbling. Scribble spontaneously at 15 months. Tower of 6 to 7 cubes at 2 years. Handedness appears at 2 years. And handedness is established by 3 years. Okay. So, these are some important fine motor milestones. The drawing skills, the child is able to precisely copy a straight line which has 2 ends. So, straight line has 2 ends. So, copies a straight line horizontal or vertical at 2 years. Circle 3 years. Round circle, round in number 3. Rectangle 4 vertices, copies it at 4 years. Also makes a plus sign. Okay, also makes a plus sign at 4 years. Triangle, copies a triangle at 5 years. Diamond at 6 years. Okay. Social milestone, social smile comes at 2 months. Mirror play 6 months. Stranger anxiety comes around 7 months. Waves bye bye 9 months. Plays peekaboo 10 months. Plays a simple ball game by 12 months. Okay, 12 months. Points to objects 15 months. Domestic mimicry and dry during daytime by 18 months. Parallel play at 2 years. Joins in play at 3 years and dry at night. But we call it nocturnal enuresis only if the baby passes involuntary urine at night beyond 5 years. Okay, 5 years is the cutoff irrespective whether it is a boy or a girl. Goes to toilet alone at 4 years. Language milestones. Vocalizes 2 months. Cooing or a more musical sound 3 months. Monosyllabic babbling like ma, ba, da 6 months. Bisyllabic babbling like mama, papa, baba 9 months. 2 to 3 words with meaning 1 year. Jargon speech at 15 months. 10 words with meaning at 18 months. 2-word sentences 2 years. 3-word sentences 3 years and tells a story, rhyme or sings a song at 4 years. So, these are the most important language milestones. Now, there is this concept of developmental red flags. So, say if we are saying that the baby sits with support around what time? 6 months. But it's not like at 7 months, if the baby is not sitting with support, it is abnormal. No. You have a margin, a range of time over which the baby can learn it. So, that is called the red flag. The upper limit of normal is called the red flag. So, if a baby is not able to sit with support even beyond 9 months, only then it is abnormal. Get the concept of red flag? So, sitting without support we know normally comes at 8 months, but it is abnormal only if the baby is not able to do this by 10 months. Again, standing with support normally comes at 9 months. Abnormal if it does not come by 12 months. Standing without support comes at 12 months. Abnormal if it has not come by 17 months. Walking with support comes at around 13 months. Sorry, walking without support, but it is abnormal if it does not come by 18 months. So, there is a range you can see. So, coming back to our question. So, this is a 9-month-old child. Cannot sit without support, but sitting without support we know normally comes at what age? 8 months. Abnormal if it does not come by 10 months. So, it is not abnormal. Child is able to roll over, says mama dada, strange anxiety is there, waves bye bye. Other milestones are in order. So, it is a variant of normal only. So, which of the following is the appropriate next step? Immediate referral for developmental assessment? No. Immediate MRI? No, we don't need to be hyper, we can wait. Reassure the parents as it is normal for age is normal. Physiotherapy as such is not required. Okay. So, that is the best answer. So, I am sure you get the hang of this question and many other questions can come from development. Heads assessment is done for, yes. So, heads is done for, who will tell me? Waiting for your reply. Meanwhile, let us discuss what is heads. Till then, I am giving you time to answer. So, heads include H is for home, E is for education, A is for activities, D is for drugs, S is for suicidality, and another S is for sex. So this assessment is done for adolescents. So I can see many of you answering correctly. So heads assessment we know is done for adolescent, and this has been asked in the INI-CET exam recently. So heads assessment is important. Okay. Inheritance pattern of various diseases again important. Which of the following is a X-linked dominant condition? So SMA, what is the mode of inheritance? We already discussed. SMN1 gene mutation, it is autosomal recessive. DMD, what is the mode of inheritance? X-linked recessive dystrophin gene. Rett syndrome, it is X-linked dominant. Achondroplasia is autosomal dominant. So our best answer here is C, Rett syndrome. Very good curve. Okay, right? So a little bit more about Rett syndrome. Because it is X-linked dominant, it is more common in girls. Inheritance we already mentioned is X-linked dominant, and most common gene mutation in this MECP2. The head circumference is normal at birth. Then what happens? Slowly there is a deceleration of head growth and the baby develops acquired microcephaly. Acquired microcephaly is there. And there is developmental delay. And there is stereotypic hand wringing movements like this. You can get a video type question also. So stereotypic hand wringing movements. Okay. Just like you're squeezing a cloth to dry it. Okay. Moving ahead, match the following. Again, a easy peasy kind of a question. Trisomy 13. So first, let's match 18. E is for E. So trisomy 18 we know is Edwards syndrome. Trisomy 21 we know is Down syndrome. Trisomy 13 is Patau, and sickle cell anemia. We know 6th position of the beta globin gene, you have replacement of glutamine by valine. So what is our best answer? So 1 with D, 2 with B, 3 with C, and 4 with A, right? So I can see, and yes, of course, let us add here the new drug which has come up, also asked in INI-CET1, is trofinetide for Rett syndrome. Very good. Proud of you, Yatinder. So trofinetide is the new drug which has come up for Rett syndrome management, right? So moving ahead, so how do you diagnose a child with Down syndrome? So we do a karyotype. So this is what a karyotype looks like. So you can see there are 2 copies of all the chromosomes except chromosome 21 which has 3 copies here. So trisomy 21 is Down syndrome. What do you see here? If you count the total number of chromosomes here, you will see that instead of 46, there are 45 chromosomes. And there is a single X chromosome and no Y chromosome. So this is 45XO. Who can tell me the diagnosis here? Waiting for your replies. Yes, very good. Kav, Vishnu. So it is Turner syndrome. So you have a single X chromosome, no Y chromosome. So it is always seen in females. Very good, all of you. Now what is this? Clinical feature seen in which case scenario? You can see cutis aplasia or scalp defect. You can see a midline cleft palate, and there is this hollow prosencephaly. There are these limb defects. There is a polydactyly. Okay, post-axial polydactyly to be more precise. So all these are features of Patau syndrome. Very good, Vishnu. So Patau syndrome or trisomy 13. Okay, it is a very severe condition. What are these? So you can see rocker bottom foot. You can see just like a rocking chair, you have a rocker bottom foot here. And you have overlapping digits, there is microcephaly, there can be internal malformations. So all these are features of Edwards syndrome or trisomy 18, right? What do you see in this karyotype? Yes, anyone? What do you see, any abnormality? So you can see 3 copies of chromosome 18. So this is a karyotype with Edwards syndrome, okay? And all these Edward, Down, Patau, in these what is happening, the number of chromosomes does not remain an exact multiple of the haploid number. So if the number of chromosomes is not 46, it is 47 or 45, then it is called an aneuploidy. So recently there was a question on aneuploidy also, which of these is an aneuploidy or which of these is not an aneuploidy. So aneuploidy is any condition where a cell's chromosome number is not an exact multiple of the haploid number. So examples are Down, Edward, Patau, Turner, all these are aneuploidies, Klinefelter, okay, because they are not exact number, chromosome number is not exact multiple of 23 here. Again, match the following with the genetic defect. INI-CET, you can expect a lot of questions on genetics. So Beckwith-Wiedemann syndrome, there is, Yes, waiting for your answers. Yes, Bloom is not a aneuploidy. Very good. Ashutosh. So, Beckwith-Wiedemann syndrome, who will tell me? So, it is a methylation abnormality on chromosome 11p15. So, chromosome 11p15 Beckwith-Wiedemann syndrome, genomic epigenetic imprinting can cause it, and its inheritance is similar to Prader-Willi and all. So, achondroplasia, we know it is autosomal dominant, but what is the gene? FGFR3. So, mutation in FGFR3. Cry-do-chat, we know deletion of the, actually it is short arm of chromosome 5. And Fragile X syndrome, expansion of the CGG, repeats in the FMR1 gene. So, our answer here is A with 2, B with 3. So, option C is the best answer here. Ashutosh, very good. Yes. Okay. So, enzyme deficient in Pompe disease. So, Pompe disease, what is the enzyme deficient? So, we all know it is acid maltase, or it is also called alpha glucosidase. Okay, alpha glucosidase, right? So, you can see a floppy child. Even at 6 months, the child has got no neck control. You can see a cardiomegaly, because in Pompe disease, what happens? There is accumulation of, this glycogen in the lysosomes, and there is cardiac muscle involvement also. Hypertrophic cardiomyopathy can be there. Okay. So, very good, Shivani. Pump is affected in Pompe's. Yes. So, the heart is affected, and you can see some ECG changes also, like short PR interval, tall QRS, and so on. Why is Pompe disease important? Because you have enzyme replacement therapy available for Pompe disease. Can you name a few more diseases for which enzyme replacement therapy is available? So, Gaucher disease, Pompe disease, Fabry disease. Amongst mucopolysaccharidosis, you have it for Hunter, Hurler, Morquio. And recently, it has also become available for Niemann-Pick disease. So, a lot of diseases have enzyme replacement therapy available now. Okay. So, 1-year-old child presents with hepatosplenomegaly and is found to have a cherry red spot on retina. Hepatosplenomegaly, cherry red spot. So, has to be a lysosomal storage disorder. The child has a normal startle reflex but has developmental regression. So, CNS involvement is there. Chest X-ray reveals bilateral pulmonary infiltrates. So, storage disorder with cherry red spot, hepatosplenomegaly, lung involvement. I get my diagnosis. Waiting for your replies. Okay. Name of enzyme replacement therapies, yes, it is important. You can have enzyme replacement therapies available for all of these except. So, amongst the mucopolysaccharidosis, you have Hurler, Hunter and Morquio. You have Gaucher disease, then Pompe disease, you have enzyme replacement therapy available. Niemann-Pick disease, you have enzyme replacement therapy. Okay. Right. So, what is my diagnosis here that I am looking at? Yes, very good guys. So, Niemann-Pick disease is the answer. You have hepatosplenomegaly, cherry red spot and pulmonary involvement, and the enzyme is sphingomyelinase. And we have enzyme replacement therapy available for this as well. Right. Hexosaminidase A deficiency we know is Tay-Sachs disease. Glucocerebrosidase is Gaucher disease. Okay. So, this is Tay-Sachs, this is Gaucher. And phenylalanine hydroxylase deficiency we know is phenylketonuria. Let us discuss a little bit about these disorders. So, Tay-Sachs disease, hexosaminidase A deficiency we already mentioned. So, in Tay-Sachs disease there is no hepatosplenomegaly usually, but cherry red spot is present. Cherry red spot present, and there is developmental regression can be there, developmental delay can be there can be excessive Mongolian spots and so on. What about Niemann-Pick disease? We already discussed there is hepatosplenomegaly, there is cherry red spot and there is pulmonary involvement, and enzyme replacement therapy is available. Okay. Gaucher disease, very important, many times INI-CET questions have come. So, there is a huge spleen, it is one of the causes of huge splenomegaly. Thalassemia major is another cause. So, splenohepatomegaly, juvenile CML is another one. So, splenohepatomegaly is there is pancytopenia because Gaucher cells are going to go and infiltrate everywhere. So, because of anemia, easy fatigability, leukopenia, infections, thrombocytopenia, bleeding. Bone pains can be there, pathological fractures can be there and neurological involvement may or may not be there. Okay. So, this is what a typical Gaucher cells looks like with a crumpled tissue paper appearance of the cytoplasm because of the accumulation of glucocerebrosides. And you can see these are again accumulated in this cytoplasm and the okay. So, what is this disease that we are talking about here? Phenylketonuria. It is deficiency of phenylalanine hydroxylase. So, phenylalanine hydroxylase deficiency, phenylketonuria, what is going to happen? Phenylalanine is going to accumulate. Excess of phenylalanine will lead to brain damage and you will have neurological manifestations. And excess of phenylalanine will lead to metabolites like phenylacetate, phenylpyruvate. So, you will get a mousy or musty urine odor. okay, urine odor. What else? Normally, normally tyrosine gets synthesized in our body. But here what will happen? Tyrosine will not get synthesized. So, there will be what? Tyrosine will become an essential amino acid. Become essential. And what else? Dopa is not getting synthesized. So, tyrosine not getting synthesized, dopa is not getting synthesized. From dopa, melanin is formed. Melanin is also not getting synthesized. So, there is hypopigmentation. Another important disorder of this pathway is homogentasic acid oxidase deficiency. This will give rise to alkaptonuria. Alkaptonuria. And very good, Shivani. So, tetrahydrobiopterin deficiency can also cause phenylketonuria because they are cofactors for this enzyme phenylalanine hydroxylase. Okay, very good. So, moving along, one more question on phenylketonuria. Mousy odor is seen in phenylketonuria. Assertion. Is it correct? Yes, we know it is. Reason for this is decrease in tyrosine, dopamine, noradrenaline? No, this is not the reason. So, there is decrease in tyrosine, dopamine, noradrenaline. This statement is correct, but this reason is not a reason for assertion, right? Okay. The mousy or musty body odor is due to phenylacetate, phenylpyruvate, all the metabolites that accumulate. So, both assertion and reasoning are correct is right. Both assertion and reasoning are incorrect is not right. Reasoning is correct but assertion is incorrect is not right. Both assertion and reasoning are correct but reasoning is not the correct explanation for assertion is the best answer. So, option D is the best answer here, right? We get that? Match the column again, a simple question repeated multiple times. So, Cori disease. So, Cori disease we know C with D. So, Cori disease is debranching enzyme deficiency. If it is a debranching enzyme deficiency, what will happen? So, there will be accumulation of abnormal branch structure in liver biopsy. So, Cori disease, branch structure in liver biopsy. McArdle disease is what deficiency? So, let us discuss the glycogen storage disorders a little, we come back to answer this. So, there are some liver glycogenosis, some muscle glycogenosis. Liver ones are 1, 3, 4 and 6. So, out of these, Wawrinka disease is glucose 6-phosphatase deficiency. Cori disease is debranching enzyme deficiency, so branch structure accumulates in the liver. Anderson disease A with B. Anderson disease is branching enzyme deficiency, C is with D. And Hers disease is hepatic phosphorylase deficiency, H with H. What about the muscle glycogenosis? Pompe disease, alpha-1,4-glucosidase or acid maltase deficiency. McArdle disease, muscle phosphorylase deficiency. So, Pompe disease we have already seen pump is involved, that means heart is involved. McArdle disease, it is mainly the skeletal muscles is involved. So, there is exercise fatigue, okay, and you can get myoglobinuria in McArdle disease, right. Tarui disease, phosphofructokinase deficiency. So, let us go back to our question. Cori disease, we saw branch structure or limit dextrin in liver biopsy. McArdle disease, we will have exercise intolerance. Pompe disease, accumulation of glycogen in lysosomes and giving rise to that skeletal and cardiac muscle involvement. Wawrinka disease, hypoglycemia with lactic acidosis. So, our best answer is A with 1, B with 3, C with 2 and D with 4. So, option B, right? Yes, I can see many of you answering correctly. Moving ahead, a 6-month-old infant. So, don't get bogged down with these big questions which can come in the INI-CET exam. So, 6-month-old infant with recurrent infections, failure to thrive, absent thymic shadow. Absent thymic shadow should ring some bell. Chest X-ray. We are thinking of, yes, we are thinking of DiGeorge syndrome. So, DiGeorge syndrome is also known as, we will go back to the question. Let us first discuss a little bit about DiGeorge syndrome. So, it is also called velocardiofacial syndrome. There is a microdeletion in 22 chromosome, long arm, 22q11. Failure of development of 3rd and 4th pharyngeal pouches. Now, the structures that develop from 3rd and 4th pharyngeal pouches will obviously get affected. So, there is thymic hypoplasia, so decreased T cells, parathyroid hypoplasia, so hypocalcemia is there. Ultimobranchial body is not formed and defect in heart and blood vessels. So, the mnemonic to remember the clinical features is catch-22. C for conotruncal or cardiac abnormalities, like they can be truncus arteriosus, they can be tetralogy of Fallot. What is truncus arteriosus? It is a condition where there is a single trunk of blood vessel arising from the heart, from which aorta will arise, from which pulmonary artery will arise. So, there is complete mixing of blood of two sides. Okay. A is for abnormal facies, you can get antimongoloid slant, abnormal nose, short philtrum. T is for thymic hypoplasia, C for cleft palate and H for hypocalcemia. Because there is thymic hypoplasia, it is mainly the T cells which are affected. Okay. And you diagnose it with serum calcium levels, echocardiogram for heart defects, chest X-ray will show absent thymic shadow, blood will show decreased CD3 T cells, lymph node parafollicular areas are depleted, and definitive diagnosis is chromosome 22q microdeletion. You can show either by MLPA. What is MLPA? Multiplex ligation dependent probe amplification, or you can show it by FISH. What is FISH? Fluorescent in situ hybridization. And thymus transplantation can be done for severe forms of DiGeorge syndrome because thymus is absent. So, you can implant cultured allogenic thymic tissue, and it can be done for severe cases. Coming back to our question. So, this we are dealing with a case of DiGeorge syndrome. Lab studies show marked CD4 T cell lymphopenia, normal B cell and CD8 cells. Which of the following statements regarding the condition are correct? The condition is caused by defective development of third and fourth pharyngeal pouches. Yes, it is correct, we saw. Thymic aplasia leads to impaired maturation of T cells is also correct. B cell function is usually severely compromised in this condition. No. I am coming to MLP again. Thymic transplantation is a definitive treatment in complete cases. Yes. So, 1, 2 and 4 are the correct statements. So, option A is the best answer. So, MLPA is, the full form is multiplex ligation dependent probe amplification. Okay, multiplex ligation dependent probe amplification. So, when we want to pick up known chromosomal loci and we want to see deletion or duplication in them, we can use multiplex ligation dependent probe amplification MLPA, or we can use FISH to diagnose it. Okay. When to start steroids in henoch-Schönlein purpura is a repeat from the previous INI-CET questions. So, what is henoch-Schönlein purpura? First, let us see, we come back to answer this question. So, henoch-Schönlein purpura, the diagnostic criteria is palpable purpura with at least one out of the following. What all? So, pain abdomen. So, there are two things clinical, two things lab findings. So, pain abdomen, arthritis or arthralgia, that means joint involvement. So, arthritis or arthralgia. Any renal involvement, any evidence of renal or kidney involvement, okay, and any biopsy showing IgA deposition, So, that is the diagnostic criteria. Usually, henoch-Schönlein purpura is a self-limiting illness, but in severe cases, you might need to start steroids. So, mild disease, only supportive treatment is required, meaning hydration, nutrition, analgesia. But if there is significant GI involvement or other life-threatening manifestations like GI bleed and all, then steroids are required. Severe disease, you can also use IV, Ig or plasma exchanges, and in chronic disease, you can use immunomodulators like azathioprine, cyclophosphamide and so on. So, significant GI involvement or life-threatening manifestations, then steroids. Coming back to our question, when to start steroids in henoch-Schönlein purpura? Skin rash involving upper limbs? No. Arthritis? No. Proteinuria? No. Severe abdominal pain would be the best answer out of the given options. Right? Okay. A child came to OPD with fever for 6 days with strawberry tongue, cervical lymphadenopathy, conjunctival congestion, peeling of skin. What is the diagnosis? We all know what are we dealing with? Yes, we are dealing with, come on. So, of course, we are dealing with Kawasaki disease. So, Kawasaki disease, the drug of choice we know is IVIG, and along with it, we also give aspirin. But the drug of choice, of course, is IVIG. So, Kawasaki disease, we diagnose it when there is fever for more than 5 days with any 4 out of 5 cream features. What are cream features? C is for conjunctivitis, which is usually non-purulent or non-exudative. R is for rash, which is the polymorphous rash. E is for edema and erythema of hands and feet. And A is for adenopathy or lymphadenopathy, which is usually posterior cervical. M is for mucositis in the form of strawberry tongue. So, what are the complications of Kawasaki disease? The most important complication of Kawasaki disease is coronary artery aneurysm. Coronary artery aneurysm can be a life-threatening, complications if treatment is not started timely. Another important complication is MAS. What is it? Macrophage activating syndrome. Okay, macrophage activating syndrome, where the child becomes very, very sick. Okay, and hyperinflammatory response is there. Now, you can get question on anticoagulation for coronary artery aneurysms in Kawasaki disease as well. So, if aneurysm has already developed, then long-term therapy is required. For small aneurysms, aspirin 3 to 5 mg per kg per day, low dose aspirin. For medium aneurysms, you need to give a dual drug therapy, that is aspirin plus clopidogrel. And for giant aneurysms more than 8 mm in diameter, you need aspirin plus anticoagulation with warfarin or low molecular weight heparin, okay? Or you can use the newer ones like apixaban. And if there is acute coronary thrombosis, because this coronary artery aneurysm can predispose to angina and even myocardial infarction, then you have to give prompt fibrinolytic therapy with tissue plasminogen activator, right? Management of a baby born to HIV positive mother who is exclusively on top feeds, which of the following? So let us first discuss a little bit about baby born to HIV positive mother, then we come back to answer this question. So, baby born to HIV infected mother, you have to do NAT at birth within 2 days. If positive, start antiretroviral therapy and repeat NAT to confirm infection. If negative, HIV-1 DNA PCR at 6 weeks using dried blood spot. And for all babies born to a HIV positive mother, irrespective of top feed or breastfeed, you have to start prophylaxis. Now we start prophylaxis with nevirapine 2 mg per kg per dose OD at birth, and dual drug prophylaxis is required if it is a high risk infant. Cotrimoxazole started at 4 to 6 week age. Now which is a high risk infant? Let us see. If the mother is not on antiretroviral therapy or received less than 4 weeks of ART, mother has unknown or high viral load, or mother newly identified during current pregnancy or within 6 weeks of delivery is a high risk infant, dual drug therapy required, both nevirapine, zidovudin for prophylaxis. Now coming to treatment of HIV in children. So treatment of HIV in children, ART should be given to all children with HIV irrespective of the CD4 count or WHO stage. High priority is given to children less than 2 years of age, WHO stage 3 or 4, and less than 5 years of age with CD4 count less than 25% or 750. But actually it is to be given to all cases if possible with HIV positive. And cotrimoxazole prophylaxis is for prophylaxis against pneumocystis jirovecii, which is the most common cause of pneumonia in a baby with HIV. Preferred first line treatment for infant less than 2 weeks, zidovudin plus lamivudin plus raltegravir. Beyond 2 weeks, abacavir or zidovudin plus lamivudin and lopinavir or ritonavir. Okay. Coming back to our question. Management of a baby born to HIV positive mother who is on exclusive top feed includes which of the following? Babies tested for HIV given zidovudin only if baby comes out to be positive? No. We know prophylaxis to be started for all babies. Babies started on zidovudin even before the results of HIV testing is available is correct. If replacement feeding is being given, no prophylaxis is wrong. Okay. And replacement feed and zidovudin is to be given for 6 months even if the child is HIV negative? No. If if the baby is on replacement feeding, then even 6 weeks, or even if if it is not a high risk baby, even 6 weeks of treatment with prophylaxis is enough if the baby is HIV negative. So our best answer is option B. Okay. Moving ahead. So what is the recommendation for breastfeeding? So ideally, you should give replacement feeding if feasible, if affordable, feasible, acceptable and safe method of feeding is available, alternate feeding. If not, then do exclusive breastfeeding. That is what in developing countries. Okay. Now the following finding can be seen in, what do you see here? You see a slap cheek appearance of rash. What is that? So that is erythema infectiosum. So what is the answer? Waiting for your reply. So erythema infectiosum we know is caused by parvovirus B19. Parvovirus B19 can also cause pure red cell aplasia or transient aplastic crisis also in cases of sickle cell anemia and in various other disorders. Molluscum contagiosum does not appear like this. There are umbilicated lesions. Hand, foot, mouth disease, we know how will it present. So the most common cause of hand, foot, mouth disease is Coxsackie A16, and there is low grade fever, and there are blisters in the oral cavity. And there can be pustules on palms and soles and hands, and there can be ulcers, and it resolves in 5 to 7 days. It is a self-limiting illness. No specific treatment is required, but it is an infectious one. So it spreads very commonly in daycares and schools, and isolation is recommended. So these are what the lesions look like, okay, in the oral cavity, palms, soles. Which of the following is true about congenital CMV infection? So 25 to 30% of the babies are asymptomatic. No, almost 80%, more than 80%, 80-90% babies of congenital CMV infection are asymptomatic. So this is not true. It is the most common cause of non-syndromic sensory neural hearing loss in children. Yes, waiting for your replies. Can be confirmed by CMV DNA PCR in the blood of the baby? No, urine is a better sample than blood. And in developing countries, major cause of congenital infection is primary infection of mother? No. Most of the mothers would have prior exposure to CMV before pregnancy. So secondary infection is more common in India, developing countries. So B is the best answer. Yes? Okay. So some congenital infection related case scenarios if you get: periventricular calcification, hepatosplenomegaly, thrombocytopenia, sensory neural hearing loss. What are we thinking? Waiting for your replies. Yes. The first case scenario, what are we thinking? Which infection? Waiting for your replies. Tell me. So we are thinking of, very good Yatinder, so we are thinking of congenital CMV. Congenital heart disease like PDA and cataract with sensory neural hearing loss, we are thinking of congenital rubella. Okay. Microcephaly, cicatrizing skin lesions and limb defects, we are thinking of congenital varicella infection. Okay. Hutchinson's triad, where do we think? So Hutchinson's triad, what is it first? So it is a triad of Hutchinson's teeth, which are what? Notched incisors. So notched incisors like this. Okay. So Hutchinson's teeth, interstitial keratitis, and sensory neural hearing loss. Okay. So all these are features of congenital syphilis, late manifestation of congenital syphilis. Congenital toxoplasmosis, you can get hydrocephalus. Okay. So instead of microcephaly, you can get macrocephaly also. So hydrocephalus can be there in congenital syphilis, congenital toxoplasmosis, and there can be parenchymal calcifications as well. Okay. And retinal pigmentary changes. So which of the following is contraindicated in a patient diagnosed with SCID, severe combined immunodeficiency? So severe combined immunodeficiency is a very severe immunodeficiency. So you avoid live vaccines. Avoid all live vaccines. So hepatitis B can be given, DPT can be given, Tdap can be given, inactivated polio can be given. We will not give MMR or measles containing vaccine because measles is a live vaccine. So D is the best answer. I can see most of you answering correctly. Very good. So Mantasha, Shivani, Invincible, Sushant, Mehrul, Vishnu. So good to see that Josh going. So national immunization schedule, a quick recap. You can get questions related to it. So at birth, we all know it is BCG, OPV 0 dose and hepatitis B birth dose. BCG, we know the route of administration is intradermal left upper arm. Okay. 6 weeks, we know 5 vaccines, OPV1, Rota1, Penta1, FIPV1 and pneumococcal conjugate 1. 10 weeks, 3 vaccines, OPV2, Rota2, Penta2. 14 weeks, again same as 6 weeks, but obviously the numbering of the dose is going to change. 9 to 12 months, what is going to happen? Measles and rubella 1, PCV booster, FIPV third dose is now introduced, and in endemic districts you have Japanese encephalitis. 16 to 24 months, MR2, DPT1 booster, OPV booster and JE2. So DPT booster and OPV booster at 18 to 24 months. 5 to 6 years, DPT booster 2. 10 and 16 years, it is capital T, small d. So that's the national immunization schedule. We need to do some of the important adverse effects also. BCG, I'm sure all of you know what are they. So there can be BCG lymphadenitis. Okay, scar due to BCG, remember, is not an adverse effect. It is a normal phenomenon that happens and it takes almost 6 to 8 weeks for the scar to develop. That can come as a question. So the sequence is like papule, vesicle, ulcer and then the scar. So BCG lymphadenitis, osteitis, disseminated infection. Okay, these are some of the adverse effects. DPT, we know, persistent inconsolable cry. So persistent inconsolable cry can be there. Okay, there can be seizures, there can be hypotonic, hyporesponsive episodes or HHE. MMR vaccine or measles containing vaccine, there can be thrombocytopenia and a measles-like illness. So thrombocytopenia and a measles-like illness can be there. Anaphylaxis can happen with any vaccine. Fever can happen with any vaccine. Redness, pain, swelling can happen with any vaccine. Okay. OPV again, you can have VAB, vaccine associated paralytic poliomyelitis, and rotavirus, the most important adverse effect is intersusception. Okay. You have the coiled spring sign, okay, and the claw sign in intersusception, a lot of radiological signs that come as question. So these are the various sites of administration. We know BCG most important is given left upper arm. MR and IPV usually given in the right arm, and rest of the vaccines are given in the anterolateral aspect of the thigh. Okay. For vaccine vial monitor, identify the correct statement. So VVM we know. So before going to the options, so we know that VVM is something that tells us about whether a vaccine has sustained heat damage or not. Okay. So heat damage or not. So you can see that if there is an inner square, outer circle. So if the inner square is lighter in color than the outer circle, you can use the vaccine provided the expiry date has not passed. But if the inner square is same or darker in color, you cannot use the vaccine. And sometimes you will see that VVM has a number on it, like VVM 8 or VVM 30. That means the vaccine can stay potent at room temperature 37 degrees Celsius for a maximum of 8 days if it is VVM 8. Okay. Coming back to the question. So, identify the incorrect statement is what is asked. Please read the question very, very carefully. Okay. So, use the vial if inner square is lighter than the outer circle. Is it correct? Yes, it is. Use the vial if inner square starts to change color but is still lighter than the outer circle is also correct. Use the vial if inner square is same color as the outer circle. No, we cannot. Discard the vial if inner square is darker than the outer circle. Yes, we will discard. So the incorrect statement here obviously is statement C. Yes, Vishnu, Invincible, Mantasha, Selvichini, very good. Poor gonadal development, micronutrient deficiency. Which micronutrient deficiency? Vitamin A, we know it causes night blindness and a lot of eye findings, but gonadal development usually not. Vitamin C, scurvy, we know subperiosteal hemorrhage, gum bleeding, scorbutic rosary and so on. Zinc deficiency can cause poor gonadal development. In addition, it can also cause acrodermatitis enteropathica, which was asked in INI-CET exam once. Acrodermatitis enteropathica, it can cause diarrhea, it can cause a variety of rashes, alopecia and so on. Iron will mainly cause anemia, right, and deficiency. So, a little bit about the micronutrient deficiencies. Nutrition and micronutrient deficiencies again very, very important. So, vitamin A deficiency, the earliest symptom of course we know is night blindness, and we know the whole grading, WHO grading or staging of vitamin A deficiency signs, xerophthalmia. So, night blindness, while the earliest sign is conjunctival xerosis, and subsequently you have what? Bitot spots, corneal xerosis, corneal ulcers and so on. Okay. Thiamine deficiency, we all know it leads to beriberi. Beriberi can be a wet beriberi where you can have congestive cardiac failure. It can be a dry beriberi with neurological symptoms. So, wet beriberi, congestive cardiac failure, so there can be edema, respiratory distress and so on. You can have a case scenario. Riboflavin deficiency, usually oral ulcers, and you have, aphthous stomatitis, and you have this angular cheilitis and so on. Nasolabial dysebacia is also there, and sometimes corneal vascular abnormalities as well. Niacin deficiency, we know pellagra is a disease of 4 Ds, diarrhea, dermatitis, dementia and even death, and you can have the Casal's necklace. Pyridoxine deficiency can cause neurological manifestations, and it is one of the causes of refractory infantile seizures. So, if you are getting a case scenario where a seizures in infant or neonate is not getting controlled even on multiple antiepileptics, think of pyridoxine deficiency. Cobalamin deficiency can cause, one is megaloblastic anemia and neurological features like subacute combined degeneration of cord. Okay. Of spinal cord. Biotin deficiency again causes neurological manifestations like developmental delay, seizures, okay, developmental delay, seizures, and it causes skin and hair abnormalities. So, skin rash, alopecia and so on. Okay. Now, moving on to malnutrition, our last topic of discussion for today. A couple of more questions to go after this. So, which of the following is the best characterizes marasmus in terms of its clinical features and nutritional effects? So, before answering this question, let us discuss a little bit about kwashiorkor and marasmus. So, edema is obviously present in kwashiorkor, absent marasmus. Kwashiorkor is mainly due to protein deficiency. Okay, and here mainly energy or calories deficient in marasmus. Appetite is poor in kwashiorkor, it is normal in marasmus. Okay, it is increased in marasmus rather. CNS involvement is there in kwashiorkor, the child has apathy or lethargy, but in marasmus no. Fatty hepatomegaly again is seen in kwashiorkor, not seen in marasmus. Skin and hair changes more common in kwashiorkor than marasmus. Whereas skin changes, we have the flaky paint dermatosis. Flaky paint dermatosis and hair changes, you have flag sign, okay, flag sign. And you have easy pluckability and hypopigmented hairs and so on. So, let us answer this question before moving ahead. So, marasmus we are talking about, okay. So, marasmus, high lipid content, edema, low protein levels, no, we know low proteins are seen in kwashiorkor, not marasmus. Calorie deficit with normal plasma protein level appears to be correct. Presence of edema and low protein levels, no. High energy levels, of course not. So, B is the best answer, okay. Moving ahead, WHO classification of malnutrition, very important. You get case scenarios and you get, you will be given some values to interpret and you have to identify and diagnose. So, it is based on weight for height. So, weight for height, if it is between -2 to -3 Z score or 70 to 79% of expected, it is wasting. Less than -3 Z score, less than 70% of expected, it is severe wasting. Again, height for age between -2 to -3 or 85 to 89% of expected, it is stunting. And more severe than that is severe stunting. So, remember, stunting indicates chronic malnutrition. So, decrease in height for age indicates chronic malnutrition, decrease in weight for height indicates acute malnutrition. All this has come as question previously. And if there is edema present, we call it edematous malnutrition, right? Clear? So, a chronically malnourished child develops hypokalemia and hypophosphatemia after receiving a high calorie diet. What are we dealing with? I need the answers. What are we dealing with here? So, what is the most likely physiological mechanism responsible for these electrolyte disturbances? So, before answering this question, tell me what are we dealing with here? So, in a chronically malnourished child, in a severely malnourished child, if you suddenly give high calories and proteins, what is going to happen? Yes, so we will have, yes, very good Mantasha. So, nutritional recovery syndrome or refeeding syndrome. What is the pathophysiology behind it? So, aggressive refeeding will cause excessive insulin release, right? And this insulin release will cause excessive protein and glycogen synthesis, and there will be increased utilization of thiamine and uptake of potassium, magnesium, phosphate inside the cells. So, you will have, because of thiamine deficiency, beriberi and heart failure, you will have hypokalemia, hypomagnesemia, hypophosphatemia. So, all these will lead to worsening of condition of the baby, respiratory distress, edema and so on. So, the most important physiological mechanism responsible is excessive insulin release due to aggressive refeeding. So, sudden insulin release is the best answer here and not the other options, right? So, the best indicator of some dehydration, severe acute malnutrition, we have already dealt with this question today. So, I want the answers from you, I am not going to tell you the answer. So, best indicator of some dehydration and severe acute malnutrition. We have already discussed the answer today. So, is it sunken eyes? No, sunken eyes can be there as such in malnourished child because of lack of subcutaneous fat. Thirst, yes, I can see Vishnu, Selvichini, Mantasha, Sushant, Yatinder, Vishnu, Mehrul Nisha, Rajvardhan, Shivani, very good. So, thirst is the best answer. Again, lethargy and skin pinch are not reliable. Okay. So, what is severe acute malnutrition? Of course, all of us know, but so many times it's been asked. So, let's just do a quick recap. So, in a child 6 months to 5 years, presence of one or more of what all? So, weight for height less than 70% of expected or less than -3 Z score. That means severe wasting, okay? Or what else? Mid upper arm circumference less than 11.5 centimeters. Or symmetric bipedal edema of nutritional origin. Symmetric bipedal edema of nutritional origin. Right? So, that is severe acute malnutrition. Now, the last question for the day. Treatment non-responsive SAM includes all except. Before answering this question, let's discuss about the management of SAM and then we close for the day. So, management of SAM, so severe acute malnutrition, initial hospitalization is required for all cases, especially those with medical complications and poor appetite. Look for the complications and treat. So, once you have admitted, look for the complications. What are the complications? If there is hypoglycemia, you give 10% dextrose, you can give it orally by nasogastric tube, or if the child is symptomatic, even IV. Hypothermia, you have to warm up the baby and remove the wet clothing, use overhead warmers, blankets and so on. Infections, you start antibiotics. If the baby is not very sick, you can start oral, otherwise IV antibiotics. Electrolyte imbalance, you have to supplement mainly potassium and whatever magnesium and whatever other electrolytes are deficient. Dehydration, you can use Resomal. okay, or you can use ORS in double dilution. Better to avoid IV fluids unless the child is in shock, okay, avoid IV. Deficiency of micronutrients, you have to supplement. Just remember that supplement all the micronutrients except iron in the initial phase because it interferes with the healing. And of course, you have to do nutritional rehabilitation. You start with low calories and proteins and you build it up gradually. So, you start with the F75 diet, you go to F100 diet, and so F75, F100 diet, and finally you gradually build up and start on the normal calories and proteins, okay. So, you have to gradually build it up. Discharge criteria in a child with severe acute malnutrition, okay. So, discharge criteria, child should be accepting well orally. Child should have lost edema and started gaining weight, started weight gain, okay. All infections and micronutrient deficiencies corrected. Mother should be confident of taking care of the child at home. Only if all the 4 criteria are satisfied, then you discharge the child from hospital. And the last thing, what do you mean by treatment failure in severe acute malnutrition? Primary failure to respond is indicated by failure to regain appetite by day 4, failure to start losing edema by day 4. So, 2 things. So, failure to regain appetite by day 4, failure to start losing edema by day 4. Presence of edema on day 10 and failure to gain at least 5 grams per kg per day by day 10. What is secondary failure? That means initially the child was responding well, but failure to gain at least 5 grams per kg per day for 3 consecutive days during the rehabilitation phase. So, moving back to our question, treatment non-responsive SAM includes all of the following except no edema reduction by day 4, yes, that is there in treatment non-responsive SAM. Appetite not increased by day 4, yes. Weight for height reaches -2 z-score, never we saw such a criteria. Weight gain less than 5 grams per kg per day by day 20 is correct. So, the best answer here is option C, right? So, these are some very important topics for your upcoming INI-CET exam. I hope you benefited from this session. If you like this session, please after the session is over, do like this video, do share it with your friends. So, this is a very quick intensive revision of a lot of important topics which you can expect in your upcoming INI-CET exam. And remember, it is not just about what you know or not know. Every exam is a test of how well you can hold your nerves. Trust yourself. Believe that if I can do it, you can also do it. I am sure if you've worked really well, have faith in yourself, just do your best without worrying about the results, and you will surely, come out with flying colors. Just put in your best and leave the rest to the higher authorities, to God, to the higher, person who is looking after all of us. So, all the very best, put in your best, and God bless you all. Thank you so much. If you have any queries, you can always, message me on my social media handles. I'll be happy to reply and help. All the best.